Welcome to the Deep Dive, your shortcut to mastering complex topics and becoming truly well-informed, even like an elite professional in the field. Have you ever felt swamped trying to understand a complex health issue, like diabetes and its intricate treatments? It can often feel like drowning in a sea of jargon and dense medical texts. Our mission today is to cut through that noise, to unpack comprehensive medical pharmacology excerpts and leave you feeling not just informed, but genuinely insightful, with surprising facts and just enough humor to keep you hooked.
That's right. Today, we're taking a deep, detailed plunge into the fascinating world of pancreatic hormones, the intricate mechanisms of glucose regulation, and the cutting-edge pharmacology of glucose-lowering drugs. We've distilled critical material from robust professional medical sources, ensuring you get a robust professional-level understanding of this vital subject. Our goal is to go very deep, cover everything in the sources, and really help you master this information.
And why does this all matter to you? Well, diabetes is incredibly prevalent, affecting millions worldwide. Understanding these fundamental principles can be profoundly empowering, whether it's for your personal health, professional curiosity, or simply to appreciate the marvels of the human body and the scientific advancements that keep us healthy. So, let's embark on this deep dive together. Our journey begins deep inside the abdomen with a small but mighty organ, the pancreas. Most people know it for its role in digestion, but today we're honing in on its hidden superpower. The endocrine pancreas, essentially your body's glucose command center. How does this control tower operate?
You've hit on a crucial distinction. Within the adult human pancreas, interspersed throughout the larger digestive gland, are approximately 1 million tiny specialized clusters of cells. These are known as the islets of Langerhans.
Islets of Langerhans.
Yeah. Think of them as microscopic islands, each acting as a miniature hormone factory, absolutely crucial for your metabolic health. They're like the elite task force in charge of keeping your blood sugar in perfect balance.
That's a great analogy, microscopic maestros. But these islets aren't just one type of cell. They're a diverse community, each with its own specific job in hormone production. What are the key players in this intricate system, as detailed in Table 41-1 from our sources?
The precise division of labor within these islets is truly fascinating. Each cell type plays a distinct, vital role. First, we have the alpha-A cells, which make up about 20% of the islet mass.
Okay, 20%.
Right. Their primary product is glucagon. Glucagon is often called the hyperglycemic factor because its main role is to raise blood glucose levels. Think of it as the emergency signal for low blood sugar, primarily by mobilizing stored glycogen from the liver. These cells also produce proglucagon, which is a precursor molecule for glucagon.
So if your blood sugar drops too low, glucagon is the alarm system telling the liver to release its stored energy. That makes perfect sense.
Precisely. And then there are the beta B cells, which are the most abundant, comprising about 75% of the islet mass.
75%. The majority of them.
Yes, the vast majority. These are the main players, responsible for producing insulin, which is the body's primary storage and anabolic hormone. Insulin acts like a key that unlocks cells to absorb glucose from the blood. But they don't just secrete insulin, they also release C-peptide and a small amount of proinsulin.
I've heard of C-peptide in diabetes monitoring. Is that why it's so important?
C-peptide is very important, yeah, even though it has no known physiologic function of its own. However, insulin and C-peptide are secreted in equimolar amounts, meaning they are released in a 1-to-1 ratio every time the beta cell secretes insulin.
1-to-1. Got it.
This makes C-peptide an incredibly useful clinical marker, allowing us to accurately measure a person's endogenous or natural insulin secretion, which is especially helpful when someone is also taking external insulin injections. Proinsulin, the precursor to insulin, does have some mild glucose-lowering action itself. The beta cells also secrete islet amyloid polypeptide, or IAPP, also known as amylin, which subtly modulates appetite, gastric emptying, and influences both glucagon and insulin secretion.
So we're already seeing this delicate balance emerging. Who else is in this cellular neighborhood contributing to this intricate control?
Next are the delta D cells, accounting for 3–5% of the islet mass. They produce somatostatin. This is a powerful, almost universal inhibitor of secretory cells.
Universal inhibitor.
Yeah. Within the islet itself, somatostatin helps dampen the release of both insulin and glucagon, acting as a local regulatory brake, ensuring that hormone release doesn't get out of control. It's like an internal modulator, keeping things in check.
Are there any other minor players that contribute to this system?
Indeed. We have the epsilon cells, which make up less than 1% of the islet mass. Their product is ghrelin, a peptide primarily known for its role in increasing pituitary growth hormone release.
Ghrelin, the hunger hormone.
Well, it's involved in that too, but here in the pancreas, its role seems linked to growth hormone. And finally, our source material mentions F cells, which can make up as much as 80% of the cells in specific pancreatic lobules, located only in the posterior portion of the head of the human pancreas. These F cells contribute to digestive processes via pancreatic peptide, a small protein whose exact mechanism of action is still being clarified.
So what's the big picture here? It's clearly not just a collection of cells, but a highly organized, interconnected system with each part influencing the others.
It truly is. This array of specialized cells and their diverse hormonal products work in a delicate, interdependent balance. Each hormone secretion influences the others, forming a complex regulatory network essential for maintaining glucose homeostasis. This means keeping your blood sugar levels within a healthy range, adapting to your body's ever-changing energy needs, and preventing the dangerous extremes of high or low glucose. It's a testament to the body's incredibly sophisticated control systems, ensuring metabolic stability.
Moving on to the star of the show for metabolic control, let's talk about insulin itself, often called the key to energy storage. When we think of insulin, we often think of a drug or a deficiency, but what exactly is it, chemically speaking?
Insulin is a remarkable protein, a true masterpiece of molecular engineering. Human insulin is a relatively small protein, built from 51 amino acids that are precisely arranged into two distinct chains, an A chain and a B chain.
A and B chains, okay.
These two chains are then held together by specific disulfide bridges, forming its critical three-dimensional structure. It's interesting to note that there are slight species differences in the amino acid sequences of these chains, which was historically important when animal insulins were more commonly used in medicine.
So it's a specific, intricately folded protein. How does the body actually make it? It's not just assembled directly, right?
That's where the fascinating processing within the beta cells comes in, beautifully illustrated in figure 41:1. Insulin doesn't start as 51 amino acids. It begins as a longer single-chain protein molecule called proinsulin.
Proinsulin, the precursor.
Exactly. This proinsulin undergoes a sophisticated processing within the beta cell's Golgi apparatus. During this process, it's precisely cleaved or cut into two main parts, the active insulin molecule and a residual connecting segment known as C-peptide. This cleavage involves the removal of 4 specific amino acids.
And as you mentioned earlier, C-peptide is an important byproduct. So once insulin is made, how is it stored before it's needed?
Inside the beta cells, insulin isn't just floating around, it's stored in specialized granules in a very stable form, hexameric crystals.
Hexameric crystals, what does that mean exactly?
It means 6 insulin molecules are precisely arranged around 2 atoms of zinc, which helps stabilize them, almost like tiny molecular storage containers. The entire human pancreas is quite efficient. It contains up to 8 milligrams of insulin, which represents approximately 200 biologic units.
200 units, wow.
Yeah. Historically, an insulin unit was defined based on its hypoglycemic activity in rabbits, but with modern purification techniques, the unit is now precisely defined by weight, with current standards equating to 28 units per milligram.
That's a lot of detail in the chemistry. Now let's move from how it's made and stored to how it's actually released. Insulin secretion isn't constant, is it? It must respond to changes in blood sugar.
No, it's a dynamic and highly regulated process. Insulin is released from the pancreatic beta cells at a low basal rate continuously, which keeps your background glucose levels stable. However, in response to various stimuli, this release can dramatically increase to a much higher stimulated rate. The most potent and primary stimulus, as you might expect, is glucose itself.
So when my blood sugar goes up, my beta cells immediately sense it. What else triggers insulin release?
Beyond glucose, several other factors are recognized as important stimuli for insulin secretion. These include other sugars like mannose, various amino acids, especially gluconeogenic ones like leucine and arginine, and a range of hormones.
Like which hormone?
Key hormonal stimulants include glucagon-like polypeptide 1, GLP-1, glucose-dependent insulinotropic polypeptide, GIP. These are our incretins, which we'll definitely get into later, glucagon itself, which can paradoxically stimulate insulin release at pharmacological levels, and cholecystokinin. High concentrations of fatty acids can also stimulate insulin release. Even your nervous system plays a role, with adrenergic sympathetic activity prompting secretion.
And certain drugs are designed to directly affect this process, right?
Yes, specific medications are designed to stimulate insulin release. This includes the sulfonylureas, meglitinides, and diphenylalanine derivatives, which are common glucose-lowering drugs. Other stimulatory drugs include isoproterenol and acetylcholine.
On the flip side, is there anything that puts the brakes on insulin release?
Absolutely. Just as crucial as the stimulators are the inhibitory signals. Hormones like insulin itself, a negative feedback loop, islet amyloid polypeptide, IAPP, somatostatin, the universal inhibitor we discussed, and leptin can all dampen insulin secretion.
Okay, so it regulates itself too.
Exactly. On the neural side, adrenergic sympathetic activity inhibits release. Chronically elevated glucose levels, ironically, can also eventually lead to inhibition or beta cell exhaustion. Low concentrations of fatty acids can also inhibit it. Certain drugs like diazoxide, phenytoin, vinblastine, clonidine, verapamil, and colchicine are also known to inhibit insulin secretion.
That's a complex interplay. So what's the fundamental mechanism by which the beta cell actually senses glucose and turns that into an insulin release signal? This seems like the core cellular dance.
This is where the magic happens, and it's beautifully diagrammed in figure 41-2. Think of it like a very precise electrical switch. Let's walk through it step by step. 1. First, when glucose levels in the blood rise, glucose is taken up by the beta cell through a specific doorway called the GLUT2 transporter. This transporter is designed to efficiently bring glucose into the cell.
Okay, GLUT2 lets the glucose in.
2. Once inside, this increased glucose leads to a significant increase in intracellular ATP levels. The beta cell essentially measures the glucose by how much energy, ATP, it can generate from it.
Right, ATP is the energy currency.
3. This increased ATP then acts as a crucial signal. It causes specific ATP-dependent potassium channels on the beta cell membrane to close. Normally, in a resting cell, these channels are open, allowing potassium to flow out, keeping the cell's interior negatively charged or polarized.
So ATP closes the potassium gates.
4. When these potassium channels close, the outward flow of potassium ions is reduced. This leads to the depolarization of the beta cell membrane, meaning the inside of the cell becomes less negative or more positively charged.
Depolarization, right, so the charge changes.
5. This change in voltage, or depolarization, is the direct signal that opens voltage-gated calcium channels on the cell membrane.
Okay, calcium channels now open.
6. As these calcium channels open, there's a rapid and significant increase in intracellular calcium. This surge of calcium is the ultimate trigger that causes the insulin-containing granules within the beta cell to fuse with the cell membrane and secrete the stored insulin hormone into the bloodstream.
That's a remarkable precision. So understanding this mechanism explains how some of our glucose-lowering drugs work.
What's fascinating here is that, indeed, the insulin secretagogue drug group, which includes the sulfonylureas, meglitinides, and diphenylene derivatives, all exert their glucose-lowering effects by directly targeting parts of this mechanism. They essentially bypass the normal glucose-sensing pathway by directly acting on the ATP-dependent potassium channels, forcing them to close, leading to depolarization, calcium influx, and thus insulin release. They essentially force the beta cell to secrete insulin.
So once insulin is out there doing its job, how does the body clean it up just to stay around indefinitely, right?
Yeah. Insulin has a very short lifespan in the circulation. The body has an efficient cleanup crew. The liver and the kidney are the two primary organs that remove insulin from the circulation.
Liver and kidney. Okay.
The liver normally clears approximately 60% of the insulin that's released directly from the pancreas, largely due to its anatomical position as the first stop for blood from the portal vein. The kidney then removes the remaining 35–40% of this endogenous hormone.
That's the breakdown for natural insulin. Does this change for people who inject insulin?
Yes, that's a crucial clinical point. In insulin-treated individuals who receive subcutaneous insulin injections, this ratio is actually reversed. In these cases, the kidney becomes the primary clearance organ, removing as much as 60% of the exogenous injected insulin, while the liver removes only 30–40%.
Wow. Okay, so that shift is important.
This shift is particularly important for dosing considerations in patients with kidney disease, as impaired kidney function could mean insulin stays in the system longer. Regardless of the source, the half-life of circulating insulin is remarkably short, typically between 3 and 5 minutes, meaning it's quickly removed from the bloodstream once it's done its work.
So if someone's body is functioning normally, what are the typical insulin levels we'd expect to see in their blood?
In healthy individuals, basal serum insulin values, that is, the low, steady release between meals, are usually in the range of 5–15 millimol or 30–90 pmol. After a meal, as glucose levels rise, the stimulated insulin release will cause a rapid peak, typically reaching 60–90 ml, 365–40 pmol.
Now that we understand how insulin is made, secreted, and cleared, let's talk about how it actually talks to cells, the insulin receptor.
Yeah.
This is where the magic of cellular communication happens, right?
Exactly. After insulin enters the circulation, it diffuses into various tissues throughout the body. There, it binds to specialized insulin receptors that are embedded in the membranes of most cells. These receptors are highly specific for insulin and bind it with extremely high affinity, even at very low picomolar concentrations.
And where are these receptors most important?
While receptors are found on most tissues, the most significant biological responses, particularly those regulating energy metabolism, occur in the primary target tissues: the liver, muscle, and adipose fat tissue.
Can you break down the structure of this receptor and how it gets activated, setting the signal inside the cell?
Certainly. The full insulin receptor is not a single protein but a complex structure, specifically two covalently linked heterodimers. Each heterodimer contains two main parts, an alpha subunit and a beta subunit, as shown in figure 41-3.
Alpha and beta.
Okay. The alpha subunit is entirely extracellular. It sits on the outside surface of the cell and acts as the specific recognition site for insulin. The beta subunit, on the other hand, spans the cell membrane, and critically, its intracellular portion contains a tyrosine kinase.
So the alpha part grabs the insulin, and that activates the beta part to do the work inside the cell.
Precisely. When an insulin molecule binds to the alpha subunits on the outside of the cell, it causes a significant conformational change in the receptor. This change brings the catalytic loops of the opposing cytoplasmic beta subunits into close proximity. This physical rearrangement then facilitates a process called mutual phosphorylation of tyrosine residues on the beta subunit.
Mutual phosphorylation.
Yeah.
Oh.
This phosphorylation event is critical. It activates the beta subunit's intrinsic tyrosine kinase activity, which is now ready to phosphorylate other proteins within the cell's cytoplasm.
And what happens once that tyrosine kinase is activated? It's like a signal going down a chain, isn't it?
Yes, it's a complex and highly orchestrated signaling cascade, often called insulin's second message. The very first proteins to be phosphorylated by the activated receptor tyrosine kinases are a group of docking proteins called insulin receptor substrates, IRS.
IRS proteins, okay.
After these IRS molecules are tyrosine phosphorylated at several critical sites, they serve as platforms. These phosphorylated IRS molecules can then bind to and activate other kinases, which are crucial for energy metabolism. The most significant of these is phosphatidylinositol 3 kinase, which leads to further phosphorylations, orchestrating various metabolic responses.
Is that the only path?
Alternatively, the phosphorylated IRS molecules can stimulate a mitogenic pathway by binding to adaptor proteins, ultimately activating the GTP binding protein, RAS, and the mitogen-activated protein kinase, MAPK system, which are involved in cell growth and division.
So how does the cell know which specific path to take, and what's the ultimate outcome of all these phosphorylations?
What's fascinating here is the specificity of this signaling. These particular IRS phosphorylated tyrosine kinases have binding specificity with downstream molecules based on their surrounding 4 to 5 amino acid sequences, or motifs. These motifs specifically recognize certain SRC homology 2, SH2 domains, on other proteins, ensuring the right signals go to the right places for specific effects. This entire intricate network of phosphorylations within the cell represents insulin's crucial second message, converting the external signal into a wide array of internal cellular actions.
So what are these multiple effects that result from this cascade across the different target cells?
They are quite diverse and fundamental to metabolism, as highlighted in Table 41-3. These effects include glucose uptake. One of the most critical effects is the translocation of glucose transporters, especially GLUT4 transporters, Table 41-2, from inside the cell to the cell membrane. This dramatically increases glucose uptake into muscle and adipose cells.
Getting the sugar in.
Makes sense? Glycogen formation. It significantly increases glycogen synthase activity, which promotes increased glycogen formation, storing glucose for later use, especially in the liver and muscle. Protein and lipid metabolism. Insulin has multiple effects on protein synthesis, ensuring that cells build and repair. It also regulates lipolysis, fat breakdown, actively inhibiting it, and promotes lipogenesis, fat creation, ensuring efficient energy storage. Cell growth. It activates transcription factors that enhance DNA synthesis and promote cell growth and division.
It sounds like a beautifully complex system. Can this receptor system be modulated or even go wrong?
Yes, its affinity for insulin can be modulated by various hormonal agents. For example, glucocorticoids are known to lower the affinity of insulin receptors for insulin, making cells less responsive. Conversely, Excess growth hormone can slightly increase this affinity. And critically, when the system goes awry, aberrant or incorrect serine and threonine phosphorylation of the insulin receptor beta subunits or IRS molecules can occur. This is a key mechanism that can lead to insulin resistance and a functional downregulation of the receptor, making cells less responsive to insulin and contributing to type 2 diabetes.
So what does this all mean when insulin finally acts on its target tissues? What's the grand orchestration it performs across the body, as detailed in Figure 41.4 and Table 41.3?
Insulin's core role is to fundamentally promote the storage of fat and glucose, both essential energy sources, within specialized target cells. Beyond just storage, it profoundly influences cell growth and orchestrates metabolic functions across a wide variety of tissues, Figure 41.4, acting like a master conductor directing the cellular machinery. Let's look at the detailed effects on its primary targets. First, on the liver.
Okay, the liver. What does it do there?
Insulin acts to reverse the catabolic features typically seen in insulin deficiency. It actively inhibits glycogenolysis, which is the breakdown of stored glycogen into glucose. It also inhibits the conversion of fatty acids and amino acids into keto acids, presenting the dangerous buildup of these acidic byproducts. Furthermore, it inhibits the conversion of amino acids into glucose through a process called gluconeogenesis.
So it stops the liver from making and releasing sugar.
Exactly. On the anabolic, or building up side, insulin strongly promotes glucose storage as glycogen by inducing key enzymes like glucokinase and glycogen synthase, while simultaneously inhibiting phosphorylase. It also significantly increases triglyceride synthesis and very low-density lipoprotein VLDL formation.
What about in muscle?
Next, in muscle tissue, insulin has a powerful anabolic effect. It notably increases protein synthesis by enhancing amino acid transport into muscle cells and boosting ribosomal protein synthesis. Just like in the liver, it also markedly increases glycogen synthesis in muscle by increasing glucose transport into the cells and inducing glycogen synthase while inhibiting phosphorylase.
Building muscle and storing energy there too, and fat tissue.
Finally, on adipose tissue, fat, insulin is crucial for storing energy. It leads to increased triglyceride storage. It does this by inducing and activating lipoprotein lipase, an enzyme that hydrolyzes triglycerides from circulating lipoproteins, allowing them to be taken up by fat cells. Insulin also ensures that glucose transport into the cell provides glycerol phosphate, which is essential for esterifying fatty acids into triglycerides, enabling fat storage. And to complete the storage picture, insulin inhibits intracellular lipase, the enzyme that would otherwise break down these stored triglycerides, ensuring that fat remains stored.
So insulin is truly the body's ultimate storage hormone, making sure we build up reserves of energy efficiently. It's like a conductor, making sure all the sections of the orchestra are playing in harmony to create energy stores. Now let's turn our attention to the other major pancreatic hormone, glucagon. If insulin is the storage master, glucagon is its counter-regulator, the mobilizer. What is glucagon chemically, and how is it processed in the body?
Glucagon is a peptide, meaning it's a short chain of amino acids, 29 of them to be precise. It has a molecular weight of 3,485.5, and interestingly, its structure is identical across all mammals. It's synthesized in the alpha cells of the pancreatic islets, as we discussed earlier, referencing Table 41.1. Like insulin, it's formed from a larger precursor molecule, approximately 18,000 molecular weight, through selective proteolytic cleavage. One of the intermediate peptides in this process is called glycantin, which contains the glucagon sequence embedded within it.
So it also starts as a larger molecule and then gets trimmed down. And once it's released, how long does it last in the body?
Similar to insulin, glucagon is rapidly cleared. It's extensively degraded in the liver, kidney, plasma, and at its tissue receptor sites. Its half-life in the plasma is very short, typically between 3 and 6 minutes, which is comparable to insulin's rapid turnover. This rapid clearance ensures that its effects are tightly controlled and quickly reversible.
Now, on to its effects. What does glucagon actually do in the body from a pharmacological perspective?
Glucagon's primary action is exerted on the liver. The first 6 amino acids at its amino terminal are critical for its function, allowing it to bind to specific Gs, protein-coupled receptors on liver cells. This binding initiates a signaling cascade that significantly increases cyclic AMP levels inside the liver cells.
And what does that increase in KNP lead to? What's the direct result for blood glucose?
This increase in KMP has several profound effects, all geared towards raising blood sugar. It facilitates the catabolism of stored glycogen, meaning it breaks down glycogen into glucose, a process called glycogenolysis. It also significantly increases gluconeogenesis, which is the creation of new glucose from non-carbohydrate sources, such as amino acids or lactate. And it promotes ketogenesis, the production of ketone bodies, which are alternative fuel sources for the brain and other tissues when glucose is scarce.
So it raises blood sugar in multiple ways.
Yes. The immediate pharmacological result of glucagon infusion, therefore, is a rapid and substantial rise in blood glucose by utilizing the liver's stored glycogen. It's essentially telling the liver, release the sugar reserves.
Does it affect muscle glycogen too, like insulin? I know insulin has effects on muscle.
Crucially, no. Unlike insulin, glucagon has no effect on skeletal muscle glycogen. This is because skeletal muscle cells lack glucagon receptors. The glycogen stored in your muscles is primarily for local muscle use, providing energy for movement, not for systemic glucose regulation.
Any other surprising effects of glucagon beyond just blood sugar?
Yes, at pharmacological concentrations, glucagon can cause the release of insulin from normal pancreatic beta cells, catecholamines from pheochromocytoma tumors, and calcitonin from medullary carcinoma cells. What's also very important is its potent inotropic and chronotropic effect on the heart.
Inotropic and chronotropic, meaning it affects heart rate and contraction strength.
Exactly. It increases both the force and rate of heart contractions. This cardiac effect is also mediated by the CAM-MP mechanism and is particularly significant because it produces an effect very similar to that of adrenoceptor agonists, but crucially, it does so without requiring functioning receptors. This is a critical point for its clinical use, especially in certain overdose situations where beta receptors might be blocked.
Interesting. Anything else?
Furthermore, large doses of glucagon can cause profound relaxation of the intestine, though this specific action may be due to mechanisms other than adenyl cyclase activation.
So what does this all mean for its actual use in the clinic? How do doctors use glucagon?
Its major clinical use is for the emergency treatment of severe hypoglycemic reactions resulting from insulin therapy, especially when a person is unconscious and unable to self-treat with oral glucose, and intravenous glucose isn't immediately available. It's a lifesaver in these scenarios.
And how is it given?
Recombinant glucagon is available in parenteral forms, intravenous, intramuscular, or subcutaneous, and significantly, as a 3 milligram nasal powder for inhalation, which is much easier for caregivers to administer in an emergency, for instance, if a child or elderly relative experiences severe low blood sugar.
And what about adverse effects with glucagon?
The main adverse effects are transient nausea and occasional vomiting. Therefore, it's important to place unconscious patients on their side after administering the drug to prevent aspiration if they vomit.
Are there any other specific medical procedures or conditions where glucagon might be used?
Yes. Intravenous glucagon is commonly employed during endoscopic retrograde cholangiopancreatography (ERCP) procedures. Its ability to relax the sphincter of Oddi facilitates the procedure, making it easier to visualize and perform interventions in the bile ducts and pancreas. Furthermore, because of its unique mechanism of increasing CAM-MP in the heart independent of VOR receptor function, it is sometimes used as an antidote in cases of beta blocker overdose, providing crucial cardiac support when receptors are blocked and unable to respond to normal stimulants.
Are there any situations where glucagon should absolutely not be given? This is critical for patient safety.
Yes, there are important contraindications. It should not be given to patients with pheochromocytoma, which is a tumor of the adrenal gland, because it can cause a dangerous release of catecholamines, leading to a significant and potentially life-threatening increase in blood pressure. It also should not be given to patients with insulinoma, which is an insulin-secreting tumor of the pancreas.
Why not insulinoma?
While glucagon initially raises blood glucose in an insulinoma patient, this can lead to a severe and dangerous rebound hypoglycemia as the tumor overreacts by releasing even more insulin after the initial glucose surge.
Now let's shift our focus to the disease itself. Diabetes mellitus. We hear the term often, but what is its precise definition?
Diabetes mellitus is broadly defined as an elevated blood glucose level. This elevation is always associated with either absent or inadequate pancreatic insulin secretion. Critically, it can occur with or without concurrent impairment of insulin action, meaning the body's cells might not be responding properly to the insulin that is being produced. This combination of problems leads to the chronic high blood sugar that defines diabetes.
And I know there are different types of diabetes. How are they classified?
The disease states underlying a diagnosis of diabetes mellitus are currently classified into 4 primary categories: type 1 diabetes, type 2 diabetes, other specific types of diabetes, and gestational diabetes mellitus. Each has a distinct underlying pathophysiology and often requires a different approach to management.
Let's start with type 1 diabetes mellitus. What's the core issue here, the fundamental problem?
The hallmark of type 1 diabetes is selective beta cell destruction, leading to a severe or absolute deficiency of insulin. This is predominantly an immune-mediated process, type 1A, where the body's own immune system mistakenly attacks and destroys the insulin-producing beta cells. There are also rare, idiopathic, type 1B, causes where the autoimmune trigger isn't identified.
Who typically gets diagnosed with type 1, and is there a genetic link?
While most patients are diagnosed before 30 years of age, the onset of type 1 diabetes can actually occur at any age, including in adulthood. It's found in all ethnic groups, though it has the highest incidence in people from Northern Europe and Sardinia. Regarding genetics, susceptibility appears to involve a multifactorial genetic linkage, meaning several genes contribute. But interestingly, only 10–15% of patients have a positive family history, meaning it often appears without a clear genetic predisposition in the immediate family.
How is it diagnosed, especially the immune-mediated type? What are the markers?
Most patients with type 1A diabetes have one or more circulating antibodies at the time of diagnosis. These include antibodies to glutamic acid decarboxylase 65, GD65, insulin autoantibody, tyrosine phosphatase IA2 ICA512, and zinc transporter 8 ZNT8.
GD65, okay.
Yeah, the presence of these antibodies is crucial. They facilitate the diagnosis of type 1A diabetes and can even be used to screen family members who might be at risk for developing the disease, allowing for early intervention. Clinically, patients with an acute symptomatic presentation of type 1 diabetes typically have already experienced significant beta cell loss. For these individuals, insulin therapy is not just important, but absolutely essential to control glucose levels and, critically, to prevent ketosis, a dangerous complication.
So it's often a sudden onset. But what about a milder, slower developing version I've heard about, sometimes called LAD?
That's a great point, and a nuance that really defines professional understanding. Some patients with type 1 diabetes experience a more indolent or slow autoimmune process. Initially, they might retain enough beta cell function to avoid immediate ketosis and can even be treated at first with oral glucose-lowering agents.
So they look like type 2 initially.
Exactly. But they eventually progress to needing insulin as their beta cell function inexorably declines. Antibody studies, particularly in Northern European populations, suggest that a significant number, up to 10–15% of individuals initially diagnosed as type 2 diabetes, may actually have this milder, late-onset form of type 1, which is termed latent autoimmune diabetes of adulthood, LADA. Recognizing LAD is key for appropriate long-term management.
That's a critical distinction for professionals. And here's where it gets really interesting. Is there any way to intervene and perhaps delay the onset of type 1 diabetes to protect those beta cells?
This is an exciting and groundbreaking development in the field. The CD3 complex is the major signal transducing element of the T-cell receptor, a key part of our immune system. It has been found that anti-CD3 antibodies can modulate the autoimmune response in individuals at risk for type 1 diabetes. This led to the development and approval of teplizumab imsor-WV.
Teplizumab, okay.
It's a humanized monoclonal antibody against CD3, approved for use in individuals at high risk for type 1 diabetes. Specifically, this means individuals aged 8 and older who have 2 positive antibodies associated with type 1 diabetes and who also have impaired glucose tolerance, which is categorized as stage 2 type 1 diabetes.
And what's the impact of this drug? What does it actually achieve?
The drug is administered as a daily infusion over 14 days. Clinical trials have shown that this treatment can significantly delay the time to onset of overt type 1 diabetes, meaning stage 3 type 1 diabetes, where symptoms become apparent and glucose levels are clearly diabetic by an impressive 25 months.
25 months, that's huge.
It's a major breakthrough in potentially altering the disease course and giving patients and families a significant symptom-free period. Common adverse reactions include transient decreases in white blood cell and lymphocyte counts, as well as rash and headache.
Now let's turn to type 2 diabetes mellitus. This seems to be a more complicated and multifaceted picture than type 1.
It is. Type 2 diabetes is a very heterogeneous group of conditions. It's fundamentally characterized by 2 main issues: tissue resistance to the action of insulin, combined with a relative deficiency in insulin secretion. Unlike type 1, where insulin is largely absent, in type 2, the pancreas does produce insulin, but the body's cells don't respond to it effectively, and often the pancreas can't produce enough insulin to overcome this resistance and meet the body's demands for glucose uptake.
So patients can present differently with varying degrees of these 2 problems.
Exactly. A given individual with type 2 diabetes may have more prominent insulin resistance or more beta cell deficiency, and their glucose abnormalities can range from mild to severe. Crucially, the circulating endogenous insulin in type 2 patients is generally sufficient to prevent ketoacidosis, a dangerous complication seen in type 1, but it's inadequate to prevent chronic hyperglycemia.
And how does treatment usually progress?
Many patients can initially control their type 2 diabetes with diet, exercise, and non-insulin glucose-lowering drugs, both oral and injectable. However, it's a progressive disease, and some patients will experience progressive beta cell failure over time and eventually may also need insulin therapy.
And what about the other types of diabetes beyond type 1 and type 2?
The category of other specific types of diabetes mellitus refers to various less common causes of elevated blood glucose. These can include conditions like pancreatectomy, surgical removal of the pancreas, pancreatitis, certain non-pancreatic diseases, or even diabetes induced by specific drug therapies such as corticosteroids. For a detailed list, clinicians and interested individuals are typically referred to comprehensive resources like the American Diabetes Association reports.
Finally, what about gestational diabetes mellitus, GDM? This is a unique category since it's associated specifically with pregnancy.
Gestational diabetes is defined as any abnormality in glucose levels that is noted for the first time during pregnancy. It's quite common, diagnosed in approximately 7% of all pregnancies in the United States.
And why does it happen during pregnancy?
The underlying mechanism is that during pregnancy, the placenta and its hormones create a degree of insulin resistance in the mother, which is most pronounced in the last trimester. This puts stress on the mother's pancreas. Risk assessment for GDM is suggested starting at the first prenatal visit with immediate screening for high-risk women. For lower-risk women, screening may be deferred until the 24th to 28th week of gestation, allowing for timely diagnosis and management to protect both mother and baby.
Understanding the types of diabetes is one thing, but how do we actually diagnose it? What are the laboratory findings that serve as our diagnostic toolkit to confirm a diabetes diagnosis?
The primary way to diagnose diabetes involves measuring glucose levels in the blood. A fasting plasma glucose, FPG, level of 126 mg/dL or 7 millimole or higher, confirmed on more than one occasion after at least 8 hours of fasting, is diagnostic of diabetes mellitus as per table 41-4 from our source. This is the cornerstone.
And if the fasting glucose is elevated but not quite at the diabetes threshold, where does that fall?
Those levels, specifically between 100 and 125 mg/dL, 5.6 to 6.9 millimole, are considered impaired fasting glucose tolerance, a category that indicates an increased risk of developing diabetes. This is commonly referred to as pre-diabetes, a critical stage where lifestyle interventions can often prevent progression to full diabetes.
Beyond a snapshot of current glucose, what about a test that gives us a longer-term picture, reflecting average blood sugar over weeks or months?
That's where hemoglobin A1C, HbA1c measurements come in. When plasma glucose levels are elevated over time, glucose irreversibly attaches to hemoglobin A in your red blood cells, a process called glycation. Since red blood cells have a lifespan of up to 120 days, the HbA1c value provides a valuable average of your plasma glucose levels over the preceding 8-12 weeks.
So it's a great gauge for long-term control, both for diagnosis and ongoing management.
Exactly. For patients who self-monitor their glucose, the HbA1c provides a valuable check on the accuracy of their daily readings. For those who don't, it's essential for adjusting treatment. The American Diabetes Association, ADA, has endorsed HbA1c as a diagnostic test. A cutoff value of 6.5% was chosen because the risk of diabetic retinopathy, a common complication, substantially increases above this value.
And what are the ranges for normal and prediabetes?
An HbA1c less than 5.7% is considered normal, while levels of 5.7 to 6.4% indicate a high risk for developing diabetes, falling into that prediabetes category.
What if HbA1c and fasting glucose aren't conclusive, but diabetes is still strongly suspected due to symptoms or other factors?
In such cases, a standardized oral glucose tolerance test, OGTT, may be performed. The patient fasts overnight, ensuring they've been receiving at least 150 to 200 grams of carbohydrate daily for 3 days prior. On the test morning, adults consume 75 grams of glucose dissolved in 300 milliliters of water. Children take 1.75 kilogram ideal body weight, consumed within 5 minutes.
They just sit there.
Patients are advised not to smoke or be active during the test. Blood samples are then collected for plasma glucose at 0 fasting and 120 minutes after glucose ingestion.
And what are the diagnostic criteria for the OGTT?
An OGTT is considered normal if the fasting value is less than 100 milligdl, 5.6 millimol, and the 2-hour value is below 140 milligdl, 7.8 millimol. A fasting value of 126 milligdl, 7 millimol or higher, or a 2-hour value greater than 200 milligdl, 11.1 millimol, is diagnostic of diabetes mellitus. Patients with a 2-hour value between 140 and 199 milligdl, 7.8, 11.1 millimol, have impaired glucose tolerance.
Is there ever a time when you don't need these specific tests?
It's also worth noting that if a patient presents with classic symptoms of diabetes, such as excessive thirst, frequent urination, and unexplained weight loss, and a random non-fasting glucose level over 200 milligdl, that alone is diagnostic and no additional testing is needed.
Why is it important to check for urine or blood ketones in diabetes? What do they tell us?
Ketone body levels are critical markers, especially for potential complications like diabetic ketoacidosis, which is a medical emergency. Ketones indicate that the body is burning fat for fuel because it can't use glucose properly, often due to insufficient insulin.
How are they measured?
Qualitative detection of ketone bodies can be done using simple nitroprusside tests, like ASA test or keto sticks, which are usually adequate for clinical purposes, even though they don't detect beta-hydroxybutyric acid, the most prevalent ketone body. Increasingly, laboratories now directly measure beta-hydroxybutyric acid, and patient use meters are available for capillary blood samples, making it easier for patients to monitor at home.
Are there specific levels to watch for?
Clinically, beta-hydroxybutyrate levels greater than 0.6 millimole warrant evaluation, and a level above 3.0 millimole indicating very high urinary ketones typically requires hospitalization.
For day-to-day management, what about self-monitoring of capillary blood glucose, BGM? How effective and reliable are these home meters?
Many blood glucose meters are available for self-monitoring from capillary blood samples, typically obtained from a finger stick. They are generally accurate, but vary in speed, convenience, required blood sample size, reporting capabilities, and cost. Some can even integrate directly with an insulin pump, providing a more comprehensive view.
But there are potential issues, right?
Yes, patients and providers must be aware of limitations. BGM strips have expiration dates, and proper storage is crucial. Expired or improperly stored strips can give inaccurate readings. Conditions impairing circulation to the fingers can also falsely lower readings. Also, alternate site testing, like on the forearm, can have a 5 to 20-minute lag in glucose response compared to finger sticks.
A lag. So when should you avoid those alternate sites?
Alternate site testing should be avoided when glucose is rapidly changing, such as after meals or if hypoglycemia is suspected, as this lag could lead to delayed treatment.
Moving from snapshots to continuous data, what's the role of continuous glucose monitors, CGM? These sound like a significant leap forward.
CGM systems represent a significant advancement in diabetes management. They use a subcutaneous sensor, typically worn for 10-14 days, to continuously measure glucose concentrations in the interstitial fluid, providing real-time glucose trends. Studies have consistently shown that both pediatric and adult patients with type 1 diabetes who use CGM devices achieve improved glucose control with a reduced incidence of hyperglycemia.
And how does the information get to the patient?
These devices transmit glucose data wirelessly to smartphones or insulin pump screens, providing real-time insights. They offer directional arrows indicating the rate and direction of glucose change, and customizable alerts for high and low glucose levels. This rich, continuous data from CGM devices is also crucial for the development and functionality of automated insulin delivery systems, often referred to as closed-loop systems.
Now, we move into the heart of diabetes treatment, medications for hyperglycemia. Let's start with a cornerstone for many, especially those with type 1, insulin preparations. What are the main types available today?
We primarily use human insulin, which comes in regular R and neutral protamine, Hagedorn, and pH formulations. Beyond these, we have 6 important human insulin analogs. 3 are rapidly acting: insulin lispro, insulin aspart, and insulin glucosine, and 3 are long-acting: insulin glargine, insulin ditamir, and insulin diglidec.
So regular, NPH, and then the analogs. Got it.
Animal insulins, while historically used, are no longer available in the United States. Most insulins are available in a standard concentration of 100 units ml, U100. However, for patients needing larger doses, higher concentrations like U200, U300, and U500 are also available, often in convenient pre-filled pens, significantly reducing the volume per injection for those with significant insulin resistance, as noted in tables 41-5 and 41-6.
Let's delve into the short-acting insulin preparations. What makes them rapid, and how do they differ from regular insulin in their action?
This group includes regular human insulin and the 3 rapid-acting analogs. All are clear solutions at neutral pH. Insulin molecules naturally exist as dimers that assemble into hexamers in the presence of zinc ions. The key difference in the rapid-acting analogs is their ingenious engineering. Specific amino acid mutations are introduced to disrupt the stabilizing intermolecular interactions of these dimers and hexamers.
So it's about breaking them apart faster to get them into action quicker. That's a clever bit of molecular design.
Exactly. This clever modification allows them to rapidly dissociate into individual monomers after subcutaneous injection, leading to much faster absorption into the circulation. They typically reach peak serum values in as little as 1 hour. And importantly, these amino acid changes in the analogs do not interfere with their binding to the insulin receptor, their circulating half-life, or their immunogenicity, all of which remain identical to human regular insulin.
Are there even faster versions now?
Yes. We even have advanced formulations like Fiasp, an insulin aspart formulation with niacinamide, and Lumyev, an insulin lispro formulation with citrate and treprostinil. Niacinamide and citrate increase vascular permeability, while treprostinil induces vasodilation, both of which dramatically accelerate subcutaneous absorption speed, leading to an even faster onset of action, about 10-11 minutes faster than their standard counterparts. This is where the innovation is really pushing the envelope for rapid action.
What are the practical clinical advantages of these rapid-acting analogs for patients?
Clinically, they offer significant advantages. For optimal pre-prandial, before meal timing, regular human insulin requires injection about 45 minutes before a meal. In contrast, the rapid-acting analogs can be injected just 15 minutes before or even immediately before or after starting a meal, which is far more convenient and flexible for patients' lifestyles.
But they need to eat quickly.
Yes, patients must ensure they ingest adequate carbohydrates early in the meal to avoid hypoglycemia. These analogs also exhibit lower variability of absorption, approximately 5% variation compared to 25% for regular insulin, making their effect more predictable. Another desirable feature is their consistent duration of action, typically around 4 hours for most commonly used dosages, unlike regular insulin, whose duration can be significantly prolonged with larger doses. This predictability is a huge advantage for fine-tuning glucose control.
And they're preferred for pumps.
They are also the insulin of choice for insulin pumps. As studies show improved HbA1c and postprandial glucose control with the same frequency of hypoglycemia compared to regular insulin in pump users.
Now let's turn to the long-acting insulin preparations. These are designed for steady basal coverage, providing a constant background level of insulin.
Correct. They provide a sustained insulin level throughout the day and night to manage glucose between meals and overnight. First, NPH, neutral protamine hagedorn or isophene insulin, is an intermediate-acting insulin. Its absorption and onset are delayed by complexing insulin with protamine.
Protamine, okay. That slows it down.
After subcutaneous injection, tissue enzymes slowly degrade the protamine, allowing for gradual insulin absorption. NPH typically has an onset of action approximately 2-4 hours, a peak action around 6-7 hours, and a duration of 10-20 hours, as illustrated in figure 41-5. Its action profile is dose-dependent, meaning smaller doses have lower, earlier peaks and shorter durations. It's often mixed with regular or rapid-acting insulins to provide both basal and mealtime coverage.
And what about the newer peakless basal insulins? Glargine is a very common one.
Yes, insulin glargine is a soluble, peakless, long-acting insulin analog. Its design involves attaching 2 arginine molecules to the B chain and substituting a glycine for asparagine at position A21. This clever modification makes it soluble in an acidic solution, but when injected into the more neutral body pH, it precipitates into a crystalline depot in the subcutaneous tissue.
So it forms a little deposit under the skin.
Exactly. From this depot, individual insulin molecules slowly dissolve and are continuously released, providing a low, steady level of circulating insulin. It has a slow onset of action, 0.5 to 1 hour, and an effective duration of approximately 24 hours, meaning it's usually given once daily. Its acidic formulation, pH 4.0, is important because it means it cannot be mixed with other insulins in the same syringe. A separate syringe must always be used to avoid disrupting its unique formulation.
Good to know. Any other advantages?
Glargine is associated with less immunogenicity than human insulin. While its interaction with the insulin receptor is similar to native insulin, it has a higher binding affinity to the IGF-1 receptor, 6 to 7 times greater, though the clinical significance of this isn't fully clear.
What about insulin detamere and degludec? How do they achieve their long-acting profiles?
Insulin detamere is modified with myristic acid, which increases its self-aggregation in subcutaneous tissue and allows for reversible binding to albumin in the bloodstream. These modifications prolong its availability, giving it a duration of action of about 17 hours at therapeutic doses. It's recommended once or twice daily for stable basal coverage and has been noted for lower within-subject variability compared to NPH and glargine, making its action even more predictable for some.
And degludec.
Insulin degludec has a unique mechanism. The 309 at B30 is removed, and lysine at B29 is conjugated to hexadecanoic acid via a gamma-glutamyl spacer. In solution, it forms dihexamers, but when injected subcutaneously, it self-associates into large multihexameric chains. These chains slowly dissolve, steadily releasing insulin monomers into the systemic circulation.
Multihexameric chains.
Wow.
This gives it a remarkably long half-life of 25 hours and a duration of action exceeding 42 hours, generally allowing for convenient once-daily injection. It's available in U100 and U200 concentrations, giving flexibility for dosing.
And now we're even talking about once-weekly insulins. That's quite a leap in convenience. Yes, the frontier continues to advance, truly pushing towards more patient-friendly options. Insulin icodec is a basal insulin analog designed for once-weekly administration. It features a C20 diacid group conjugated to a lysine, resulting in strong, reversible binding to albumin, which significantly delays its subcutaneous absorption. Additionally, specific amino acid substitutions, A14E, B16H, B25H, attenuate its insulin receptor affinity and increase its resistance to degradation, contributing to its prolonged action profile. This could be a game changer for adherence and convenience.
So, given all these types, how do clinicians often combine them for patients to provide comprehensive glucose control?
For patients who need both basal and mealtime coverage, there's a strong rationale for mixtures of insulins. Intermediate-acting NPH insulins typically take several hours to reach therapeutic levels, often requiring rapid or short-acting insulin supplements before meals. For patient convenience, these can be mixed in the same syringe immediately before injection.
Are there stable pre-mixed options for convenience?
Yes. Stable pre-mixed human insulins, for usually 70% NPH and 30% regular, are available for convenience, especially for patients with visual problems or dexterity issues. Historically, premixed preparations of rapidly acting insulin analogs with NPH were unstable due to an exchange phenomenon. To remedy this, intermediate insulins composed of isophane complexes of protamine with the rapid-acting insulin analogs, such as neutral protamine, Lispro, NPL, or aspartate were developed.
So they made stable analog mixes.
Yes. This allowed for stable premix analog insulins like Humalog Mix 7525, Humalog Mix 5050, and Novolog Mix 7030. These offer a faster onset of glucose-lowering activity compared to the older infregular mixtures, and are more effective in achieving glucose targets post-meal, and can be given within 15 minutes before or after a meal. It's important to remember that the long-acting insulins glargine and detamere cannot be mixed with other insulins in the same syringe due to their unique acidic formulations.
Beyond the insulin itself, how has the technology for insulin delivery systems evolved? It seems like a huge area of innovation.
The evolution has been remarkable, truly transforming daily life for many patients. From basic syringes to highly sophisticated pumps, technology has revolutionized how insulin is delivered. Insulin syringes and needles are still fundamental tools. Disposable plastic syringes are available in various sizes, often with low-dose options for easier reading and half-unit markings. Different needle lengths are available, with longer ones preferred for overweight or obese patients to ensure proper subcutaneous absorption.
And site rotation is key, right?
While alcohol isn't strictly necessary if the skin is clean, rotation of injection sites is highly recommended to prevent lipohypertrophy, a localized thickening of subcutaneous fatty tissue, which can impair insulin absorption, leading to unpredictable glucose control.
And what about pens, which are so common now?
Insulin pens offer a convenient alternative to vials and syringes. Both reusable pens with cartridges and disposable pre-fill pens are widely available for almost all insulin types and mixtures, making administration much simpler and more discreet. A newer innovation is smart pens, which pair with smartphones to assist with dose calculation and tracking injections, improving adherence and record keeping for patients and their healthcare teams.
Here's where it gets really interesting. Continuous subcutaneous insulin infusion devices, or insulin pumps. How do these work, and for whom are they best suited?
Insulin pumps, like those from Medtronic MiniMed, Insulet, Omnipod, and Tandem, are battery-operated devices worn externally. They deliver short-acting insulin continuously as a basal rate and as boluses for meals. The catheter connecting the insulin reservoir to the subcutaneous cannula can be disconnected for temporary removal, for instance, during bathing or sports.
And the Omnipod is different how?
The Omnipod is unique in being a disposable, waterproof patch pump that integrates the reservoir and infusion set into a single unit, eliminating the need for a separate catheter and allowing for wireless control from a personal digital assistant.
What are the main advantages of these pumps for patients? It seems like they offer a lot of flexibility.
A major advantage is the ability to establish a basal profile tailored precisely to the patient's individual needs, which significantly improves overnight and between meals glucose control. They also help in managing glycemic excursions during exercise, allowing for on-the-fly adjustments. Most pumps include sophisticated software to assist patients in calculating mealtime boluses based on their current glucose reading and carbohydrate intake.
And they help prevent mistakes.
They also track the time since the last insulin bolus, which helps prevent overcorrection and subsequent hypoglycemia, a significant safety feature.
Who are ideal candidates for pump therapy?
CSII therapy is most appropriate for motivated, mechanically inclined, type 1 diabetes patients who are well educated about diabetes management, diet, insulin action, treatment of hypoglycemia and hyperglycemia, and are willing to monitor their blood glucose frequently, 4 to 6 times a day.
Are there downsides?
Potential complications include ketoacidosis, which can occur if insulin delivery is interrupted, NG pump malfunction or detachment, and skin infections at the infusion site. A disadvantage is the cost and the additional time required by clinicians to initiate and manage therapy. Almost all patients using pumps utilize rapid-acting insulin analogs due to their rapid onset and offset. We also have patch pumps like Vigo and Secure Simplicity designed for type 2 patients, offering fixed basal rates and meal coverage boluses, simplifying insulin delivery for that population.
And the ultimate goal for many, closed-loop systems, or what people are calling the artificial pancreas. This sounds like the next frontier in automated care.
This is truly at the forefront of diabetes technology and represents a significant step towards automating diabetes care. Algorithms have been developed to use glucose data from CGM systems to automatically adjust insulin delivery by CSII pumps. These closed-loop systems have demonstrated success in reducing nighttime hypoglycemia and lowering HbA1c levels.
Can you give some examples?
Examples include the MiniMed 770G, which targets a sensor glucose of 120 mg/dL, 6.7 mg, and the Tandem Control IQ targeting 112.5 mg/dL, 6.25 millimol. The Omnipod 5 targets a user-programmed glucose value between 100 and 150 mg/dL. While these systems automate basal insulin delivery, the patient is still responsible for manually bolusing insulin for meals and snacks, so it's not fully autonomous yet.
And people are even building their own.
It's also worth noting the existence of patient-developed open-source algorithms like Loop, which use CGM data to automatically adjust insulin delivery via their pumps. These open APS systems, while innovative, have not been approved for use by the FDA.
Another truly unique delivery system is inhaled insulin. How does that work, and what are its particular advantages and disadvantages?
Technosphere insulin, Afresa, is a dry powder formulation of regular human insulin approved for adults with diabetes. It's made of tiny 2 to 2.5 nim crystals of an excipient, fumarole dictopiprazine, that provide a large surface area for insulin absorption. When inhaled from a small, single-use device, pharmacokinetic studies show incredibly rapid peak levels achieved within 12-15 minutes, with concentrations declining to baseline in 3 hours.
That's much faster than injection.
Yes, significantly faster in onset and shorter in duration than subcutaneous insulin, making it a very quick-acting mealtime option.
So it's very fast, but does it work as well as injected insulin for glucose lowering?
In clinical trials, inhaled insulin combined with injected basal insulin was found to be as effective in lowering glucose as injected rapid-acting insulin combined with basal insulin. It's formulated as single-use, color-coded cartridges delivering 4, 8, or 12 units, taken immediately before the meal. The manufacturer provides a dose conversion table to guide patients on which cartridge to use based on their previous injected rapid-acting insulin dose.
What are the main considerations or side effects with inhaled insulin? I imagine lung health is a factor.
You're right to consider that. The most common adverse effect reported was cough, affecting 27% of trial patients. A small, persistent decrease in pulmonary function, forced expiratory volume in 1 second, FEV1, was also observed. Therefore, inhaled insulin is contraindicated in persons who smoke or those with chronic lung disease, such as asthma and chronic obstructive pulmonary disease. Spirometry should be performed to identify potential lung disease before initiating therapy and regularly monitored thereafter.
Any other concerns?
It's also important to be aware that during clinical trials, 2 cases of lung cancer were observed in patients taking inhaled insulin compared to none in comparator groups, though the relevance to human therapy remains unclear.
It's fascinating how the body processes these complex molecules. But can the body's own immune system react to insulin therapy, potentially causing issues? What's the immunopathology of insulin therapy?
Yes, the immune system can respond to insulin therapy, and it's an important aspect for professional understanding. Patients can produce at least 5 molecular classes of insulin antibodies: IgA, IgD, IgU, Ig, and IgM. There are 2 major types of immune disorders associated with this. First, insulin allergy.
An actual allergy to insulin?
Yes, it's a rare immediate type hypersensitivity reaction. It typically manifests as local or systemic urticaria hives, resulting from histamine release from tissue mast cells sensitized by anti-insulin IgE antibodies. In severe cases, it can escalate to anaphylaxis. Historically, sensitivity was often to non-insulin protein contaminants. However, the development of human and analog insulins, which are purer and more similar to endogenous insulin, has markedly reduced the incidence of insulin allergy, especially local reactions at the injection site.
And what about insulin resistance related to the immune system?
That's the second type, immune insulin resistance. Most insulin-treated patients will develop a low titer of circulating IgG anti-insulin antibodies. However, these usually neutralize the action of insulin to a negligible extent and don't cause significant clinical problems. Rarely, though, the titer of these insulin antibodies can become high enough to cause significant clinical insulin resistance, meaning the patient needs much higher doses of insulin to achieve control. This more severe form can also be associated with other systemic autoimmune processes, such as lupus erythematosus.
You also mentioned problems at the injection sites, changes in the fat tissue. What is lipodystrophy at injection sites?
Lipodystrophy refers to changes in the fat tissue under the skin at injection sites, and it's a practical concern for patients. Historically, with older animal insulin preparations, injections sometimes led to atrophy, a loss of subcutaneous fatty tissue at the injection site, creating depressions. However, with the development of human and analog insulin preparations, which have a neutral pH, this type of immune-mediated complication is almost never seen. In fact, injecting these newer preparations directly into an atrophic area can often help restore normal contours.
So, atrophy isn't much of a problem anymore, but what about the opposite effect, where tissue thickens?
The opposite, hypertrophy, a thickening or lump formation of subcutaneous fatty tissue, still remains a problem if insulin is injected repeatedly at the exact same site without rotation. This can lead to variable and unpredictable insulin absorption from that site, making glucose control much harder. The solution is simply to avoid injecting into the specific hypertrophied area, allowing it to recover, and consistently rotating injection sites to prevent its recurrence. This is a critical piece of patient education.
We've covered insulin and glucagon in depth, but many patients with type 2 diabetes don't start on insulin, and some may never need it. So let's explore the vast medications for treatment of type 2 diabetes, the broader pharmacological arsenal beyond insulin. How do we categorize these glucose-lowering agents to make sense of them all?
Understanding these agents effectively means categorizing them by their primary mechanism of action. Our sources describe 6 major mechanisms, giving us a clear framework. 1. Drugs that stimulate insulin secretion, often by binding to the sulfonylurea receptor. 2. Drugs that primarily lower glucose levels through their actions on the liver, muscle, and adipose tissue. 3. Drugs that principally slow the intestinal absorption of glucose. 4. Drugs that mimic or prolong the action of incretins, leveraging gut hormones. 5. Drugs that inhibit the reabsorption of glucose in the kidney, a unique approach. 6, and finally, drugs that act by other or less defined mechanisms.
Let's start with the first group, drugs that primarily stimulate insulin release, often called secretagogues. How do these work and what are the main classes in this group?
This group includes sulfonylureas, meglitinides, and diphenylamine derivatives. Their shared mechanism, as we touched on earlier with insulin secretion, is key, referencing figure 41-2. They all bind to a high-affinity sulfonylurea receptor that's associated with an ATP-sensitive potassium channel on the beta cell membrane.
The same channel involved in glucose sensing.
Exactly. Binding to this receptor inhibits the efflux of potassium ions through the channel, which results in depolarization of the beta cell. This depolarization then opens voltage-gated calcium channels, leading to a calcium influx, and this increased intracellular calcium ultimately triggers the release of preformed insulin from the beta cells. They essentially nudge the pancreas to produce more insulin, regardless of the immediate glucose level.
So let's dive into sulfonylureas, a very common and long-standing class. What should we know about their safety and how they're processed in the body?
Sulfonylureas are well established. They are primarily metabolized by the liver, and their metabolites are either weakly active or inactive, with the exception of acetohexamide, which is rarely used now. These metabolites are then excreted by the kidney, and for second-generation sulfonylureas, partly by the bile. Idiosyncratic reactions like skin rashes or hematologic toxicity are rare. The second-generation drugs have a greater affinity for their receptor compared to the first-generation agents.
What does that mean practically?
This means lower effective doses and plasma levels, which in turn reduces the risk of drug-drug interactions as they compete less for plasma binding sites or hepatic enzymes.
I recall some historical controversy around sulfonylureas and cardiovascular risk from decades ago. What's the current understanding and how is that resolved?
This is a fascinating historical context important for professionals. In 1970, the University Group Diabetes Program, UGDP, reported an increased number of cardiovascular deaths in type 2 patients treated with tolbutamide, a first-generation sulfonylurea. However, this study had significant design flaws and its conclusions were not widely accepted by the medical community. Crucially, the much larger and more robust United Kingdom Prospective Diabetes Study, UKDS, a landmark long-term study, did not find an untoward cardiovascular effect of sulfonylurea usage. Therefore, sulfonylureas continue to be widely prescribed and remain a valuable tool in diabetes management.
Can you highlight some key individual sulfonylureas, particularly the second-generation ones, and any important distinctions between them?
Of the first-generation drugs, tolbutamide is well absorbed but rapidly metabolized, giving it a relatively short duration, 6 to 10 hours, and a half-life of 4 or 5 hours. It's considered relatively safe in the elderly and in patients with renal impairment due to its short half-life and liver inactivation. Other first-generation drugs like chlorpropamide, talazimide, and acetohexamide are now rarely used due to less favorable profiles or more effective alternatives.
And the second-gen ones.
Among the second-generation sulfonylureas, which are 200 times more potent than tolbutamide, we have glyburide, glipizide, and glamepiride. These should be used with caution in patients with cardiovascular disease or in the elderly, where hypoglycemia would be particularly dangerous due to their prolonged action. Glyburide, also known as glibenclamide, is metabolized in the liver to products with low hypoglycemic activity. Despite its assay-specific plasma half-life of only 1 to 2 hours, its biological effects can persist for 24 hours.
24 hours from a 1-2 hour half-life.
This is partly because glyburide uniquely binds to and becomes sequestered within the pancreatic B cell, contributing to its prolonged effect. However, due to its active metabolites and prolonged effect, glyburide should not be used in liver failure or chronic kidney disease due to an increased risk of hypoglycemia, especially in the elderly. Glipizide has the shortest half-life, 2 to 4 hours, among the more potent sulfonylureas. While food can delay its absorption, its clinical significance with chronic use is less clear. It's metabolized in the liver to inactive products, and the remainder is excreted unchanged by the kidney.
So glipizide might be safer in kidney issues.
Because of its shorter duration and inactive metabolites, glipizide is often preferred over glyburide in the elderly and for those patients with renal impairment. Glyburide is used once daily and achieves blood glucose lowering with the lowest dosage of any sulfonylurea compound, 1 milligram effective, max 8 milligrams, with a half-life of 5-9 hours and is completely metabolized to weak or inactive metabolites.
What are the common side effects of sulfonylureas and any important drug interactions that patients or prescribers should be aware of?
The most common adverse effects are hypoglycemia, low blood sugar, and weight gain. As for drug interactions, some sulfonamides, like sulfasalazole, and oral azole antifungal medications can inhibit tolbutamide metabolism, leading to prolonged hypoglycemia. Glyburide can occasionally cause flushing after ethanol ingestion and slightly enhances free water clearance, which is a minor but notable effect.
What about meglitinide analogs like repaglinide? How do they differ from sulfonylureas, and what's their niche?
Repaglinide and mitiglynide, not available in the U.S., are insulin secretagogues that also modulate beta cell insulin release by regulating potassium efflux, similar to sulfonylureas. They share some binding sites with sulfonylureas, but also have unique ones. Repaglinide has a very fast onset of action, with peak concentration and effect within approximately 1 hour after ingestion, but a shorter duration of action, 4 to 7 hours.
So they're quicker and shorter acting.
Exactly. It's primarily cleared by hepatic CYP3A4, a liver enzyme, with a plasma half-life of 1 hour. Because of its rapid onset and short duration, repaglinide is specifically indicated for controlling postprandial glucose excursion, the spikes in blood sugar, right after meals, and is taken just before each meal. Doses 0.25 to 4 milligrams, max 16 milligd. Hypoglycemia is a risk if a meal is delayed or skipped. Importantly, it can be used in patients with renal impairment and in the elderly, and it contains no sulfur in its structure, making it a viable option for type 2 patients with a severe sulfur or sulfonylurea allergy.
And the diphenylalanine derivative, nateglinide, what's its role?
Nateglinide also stimulates a rapid and transient release of insulin from beta cells via the ATP-sensitive K+ channel closure, just like the meglitinides. It's quickly absorbed, peaking in less than 1 hour, with a half-life of about 1 hour, and an overall duration of action around 4 hours. It's metabolized in the liver by CYP2C9 and CYP3A4.
So similar niche to repaglinide.
Like repaglinide, it's taken before meals to reduce postprandial glucose. It's efficacious alone or with non-secretagogue agents, and its main adverse effect is hypoglycemia. It can also be safely used in patients with renal impairment and in the elderly.
Next, let's explore drugs that primarily lower glucose via liver, muscle, and adipose tissue. And the most famous one here is metformin. What's its structure, and how does it work to reduce blood sugar?
Metformin is a big one-eyed, and its chemical structure is provided in our source material. Its therapeutic effects primarily stem from increasing hepatic adenosine monophosphate activated protein kinase, AMPK, activity inside liver cells. This leads to a significant reduction in hepatic gluconeogenesis, the liver's production of new glucose, and also lipogenesis, fat production. Metformin is also a substrate for organic cation transporter 1, OCT1, which is abundantly expressed in both hepatocytes, liver cells, and the gut, aiding its transport and action.
How is it processed and eliminated from the body?
Metformin has a half-life of 1.53 hours, is not bound to plasma proteins, and notably, it is not metabolized in the body. It is excreted unchanged by the kidneys as the active compound. This is why kidney function is so critical for its safe use.
That brings up a serious concern I've heard about. Lactic acidosis.
Yeah.
How does that relate to metformin, and what's the risk?
This is a crucial point to understand for an elite professional. Because metformin blocks gluconeogenesis, it may also impair the hepatic metabolism of lactic acid. In patients with renal insufficiency, metformin can accumulate, significantly increasing the risk of lactic acidosis, a rare but serious and potentially life-threatening complication. It's a dose-related risk.
So kidney function is the key safety check.
Yes. Metformin can be safely used in patients with an estimated glomerular filtration rate, eGFR, between 60 and 45 mmol per 1.73 mL2. It should be used cautiously in patients with stable eGFR between 45 and 30 mmol per 1.73 mL/mL. However, it is contraindicated if the eGFR is less than 30 mmol per 1.73 mL2. Similarly, patients with decompensated liver failure should not take metformin due to this increased risk of lactic acidosis, as their liver's ability to clear lactate is already compromised.
So despite this risk, it's still often the first-line drug, right? And what are its broader benefits beyond just glucose lowering?
Absolutely. The current recommendation from major medical bodies is to start metformin at the diagnosis of type 2 diabetes, unless there's a contraindication. The UK PDS, United Kingdom Prospective Diabetes Study, famously reported that in obese type 2 patients, metformin notably decreased the risk for both cardiovascular disease and microvascular disease. It's also widely used in combination with other oral and injectable non-insulin agents, and with insulin when monotherapy is insufficient.
Can it actually prevent diabetes?
What's more, the landmark Diabetes Prevention Program concluded that metformin is efficacious in preventing the new onset of type 2 diabetes in middle-aged, obese individuals with impaired glucose tolerance. Epidemiologic studies even suggest that metformin use may reduce the risk of some cancers, making it a drug with wide-ranging benefits.
What are the typical dosages and common side effects of metformin?
While the maximal dosage is 2,550 milligrams daily, little additional benefit is seen above 2,000 milligrams daily. Treatment typically starts at 500 milligrams daily with a meal and is gradually increased in divided doses, often to 1,000 milligrams twice daily, to minimize side effects.
And the side effects are usually digestive.
The most common adverse effects are gastrointestinal, anorexia, nausea, vomiting, abdominal discomfort, and diarrhea, occurring in up to 20% of patients. These are dose-related, tend to occur at the onset of therapy, and are often transient. Taking metformin with food or using an extended-release formulation can help, but in 3–5% of patients, therapy may need to be discontinued due to persistent diarrhea.
Any other important long-term considerations with metformin beyond the GI effects?
Yes, metformin can interfere with the calcium-dependent absorption of the vitamin B12 intrinsic factor complex in the terminal ileum. This can lead to vitamin B12 deficiency after many years of use. Periodic screening for B12 deficiencies should be considered, especially in patients presenting with peripheral neuropathy or macrocytic anemia, as these can be symptoms of B12 deficiency. Increased calcium intake may help prevent this malabsorption.
And what about the radiocontrast issue we sometimes hear about when patients need imaging?
Acute kidney failure can rarely occur in patients receiving radiocontrast agents, which are dyes used in certain medical scans. Therefore, metformin therapy should be temporarily held on the day of radiocontrast administration and restarted a day or two later, only after confirmation that renal function has not deteriorated. Renal function should be checked at least annually in patients on metformin therapy, and lower doses should be used in the elderly or in those with eGFR between 30 and 45 mmHg per 1.73 ml2, as they may have limited renal reserve, making them more susceptible to metformin accumulation.
Let's move to thiazolidinediones, TZDs like pioglitazone. These also improve insulin sensitivity, but they have a history of significant safety concerns, making their use more nuanced. That's a critical point to highlight for any professional. Thiazolidinediones are unique in that they are ligands of peroxisome proliferator activated receptor gamma, PPAR. These are nuclear receptors found primarily in fat, muscle, and liver cells. Activating these receptors essentially modulates the expression of genes involved in lipid and glucose metabolism, insulin signal transduction, and the differentiation of adipocytes, fat cells, and other tissues. What effects do you see when these genes are modulated?
Their observed effects include increased glucose transporter expression, GLUT1 and GLUT4, decreased free fatty acid levels, decreased hepatic glucose output, increased adiponectin, a beneficial hormone from fat cells, decreased resistin, a hormone that can promote insulin resistance, and increased differentiation of preadipocytes into adipocytes. They also decrease markers of inflammation like PI1, MMP9, C-reactive protein, and IL-6. Their primary clinical effect is to lower insulin requirements by improving insulin sensitivity, making the body's existing insulin work more effectively.
So they make the body more responsive to the insulin that's already there. Only pioglitazone is currently available in the U.S., correct?
That's right. Pioglitazone is the primary one available today. It has some PPAR as well as PPAR activity. It's absorbed within 2 hours of ingestion, and while food may delay uptake, its total bioavailability isn't affected. However, its absorption can be decreased by concomitant use of bile acid sequestrants. Pioglitazone is metabolized by CYP2C8 and CYP3A4, which are liver enzymes, and it can affect the bioavailability of other drugs metabolized by these same enzymes, including estrogen-containing oral contraceptives, so additional contraception methods are advised. It's typically taken once daily, 15–30 milligrams max, 45 milligram. Rosiglitazone, the other thiazolidinedione, has been discontinued by the manufacturer.
Beyond glucose lowering, do they have other beneficial effects, perhaps on lipid profiles or vascular health?
Yes, these drugs have some important additional effects. Pioglitazone specifically lowers triglycerides and increases high-density lipoprotein HDL cholesterol without significantly affecting total or low-density lipoprotein LDL cholesterol. They've also been shown to improve the biochemical and histologic features of non-alcoholic fatty liver disease, NAFLD.
Interesting. Any effects on blood vessels?
They seem to have a positive effect on endothelial function, lining of blood vessels. Pioglitazone, for instance, reduces the re-narrowing of blood vessels, neointimal proliferation, After coronary stent placement, and rosiglitazone was shown to reduce microalbuminuria, an early sign of kidney damage. Pioglitazone has even shown cardiovascular protection, reducing the risk of subsequent stroke or myocardial infarction in non-diabetic insulin-resistant patients with a history of ischemic stroke or TIA.
Now let's address the elephant in the room. The safety concerns and side effects for this class are quite significant and have limited their use. What are the key issues for a professional to be aware of?
Indeed, this is a crucial area for any professional. The controversy surrounding rosiglitazone is particularly notable. A meta-analysis of randomized clinical trials suggested an increased risk of angina pectoris or myocardial infarction, leading to its suspension in Europe and severe restrictions in the United States. While a subsequent large prospective clinical trial, the RECORD study, failed to confirm these meta-analysis findings, the U.S. eventually lifted restrictions, but rosiglitazone, Avandia, has since been discontinued by the manufacturer. This illustrates how even highly effective drugs can face significant scrutiny.
What are the other major side effects that apply to the class, particularly fluid retention and bone issues?
Fluid retention occurs in about 3–4% of patients on thiazolidinedione monotherapy, and more frequently, 10–15%, with concomitant insulin therapy. This can lead to or worsen heart failure, and the drugs are therefore contraindicated in patients with New York Heart Association Class 3 and 4 cardiac status due to the increased risk of fluid overload.
Okay, so heart failure is a big one. What else?
Macular edema, affecting the eye, is a rare adverse effect that typically resolves when the drug is discontinued. A significant concern, particularly for women, is the loss of bone mineral density and increased atypical extremity bone fractures, which is postulated to be due to decreased osteoblast formation and is likely a class effect across TCDs. Other adverse effects include anemia, possibly due to a dilutional effect from increased plasma volume, and weight gain, especially when used with sulfonylureas or insulin, which is due to both fluid retention and an increase in total fat mass.
And there were concerns about bladder cancer with pioglitazone. What's the latest understanding?
Yes. Preclinical trials observed bladder tumors in male rats on pioglitazone. Initial clinical reports suggested this might also be true in humans. However, a 10-year observational cohort study failed to find an association with bladder cancer, and a large multi-population pooled analysis also found no association. Yet another population-based study did find pioglitazone, but not rosiglitazone, associated with an increased risk. So the data remains conflicting for humans, and careful consideration is still warranted.
And liver injury, which led to the withdrawal of the first drug in this class.
Troglitazone, the very first medication in this class, was withdrawn due to cases of fatal liver failure. Although rosiglitazone and pioglitazone haven't been reported to cause liver injury to the same extent, they are not recommended for use in patients with active liver disease or pretreatment elevation of alanine aminotransferase, ALT, more than 2.5 times normal. Liver function tests should be performed before starting treatment and periodically thereafter to monitor for potential issues as a precaution given the class history.
Let's discuss drugs that affect absorption of glucose, specifically the glucosidase inhibitors. How do these work to reduce glucose, and why are they less commonly used?
These drugs, which include acarbose and miglatol and voglibose, not in the U.S., work by competitively inhibiting the intestinal glucosidase enzymes. These enzymes are located in the brush border of the small intestine and are responsible for breaking down complex starches and disaccharides into absorbable glucose. Their primary effect is to delay the digestion and absorption of starch and disaccharides in the intestine, thereby reducing the sharp rise in glucose levels after meals or post-meal glucose excursions.
And how are they absorbed?
Acarbose is barely absorbed, while miglatol is structurally similar to glucose and is absorbed, cleared by the kidney, and thus not for renal failure patients.
What are the common side effects that often limit their use and make them less popular?
The most prominent adverse effects of glucosidase inhibitors are gastrointestinal, flatulence, diarrhea, and abdominal pain. These symptoms arise because undigested carbohydrates reach the colon and are fermented by bacteria, releasing gas. While these symptoms tend to diminish with ongoing use as the body adapts, chronic exposure can induce glucosidase expression further down the small intestine. They are significant and often lead to patient discontinuation.
What about low blood sugar with these?
If hypoglycemia occurs when these drugs are used with an insulin secretagogue, it must be treated with glucose, dextrose, not sucrose, because sucrose's breakdown may be blocked by these inhibitors. Additionally, an increase in hepatic aminotransferases has been noted with acarbose at higher doses, which resolves upon stopping the drug. Overall, they are infrequently prescribed in the U.S. due to their prominent GI adverse effects and relatively modest glucose-lowering benefit compared to other more effective options.
Now on to an exciting area. Drugs that mimic incretin effect or prolong incretin action. This involves the gut-brain connection. What exactly is the incretin effect and why is it so important?
What's fascinating here is that an oral glucose load actually provokes a higher insulin response compared to an equivalent dose of glucose given intravenously. This difference is due to the release of gut hormones, known as incretins, primarily glucagon-like peptide 1, GLP-1, and glucose-dependent insulinotropic polypeptide, GIP. These incretins released when you eat amplify the glucose-induced insulin secretion, essentially supercharging the insulin response to food in a glucose-dependent manner.
So they supercharge the insulin response to food. And what are the actions of GLP-1 specifically that make it a target for drugs?
Yes, they amplify it. When GLP-1 is infused in type 2 diabetes patients, it stimulates insulin release and lowers glucose levels. This effect is glucose-dependent, meaning insulin release is more pronounced when glucose levels are high, but less so when glucose is normal, giving GLP-1 a lower risk for hypoglycemia compared to sulfonylureas. Beyond insulin stimulation, GLP-1 also suppresses glucagon secretion, delays gastric emptying, reduces islet beta cell apoptosis, programs cell death in laboratory settings and in animals, inhibits feeding via a central nervous system mechanism. Patients on GLP-1 therapy often report feeling less hungry, contributing to weight loss.
Why can't we just use native GLP-1 as a drug? It sounds so promising.
The challenge is that native GLP-1 is rapidly degraded by the enzyme dipeptidylpeptidase 4, DPP4, and other enzymes, and is also cleared by the kidney. This means the native peptide cannot be used therapeutically due to its extremely short half-life.
So what are the strategies to overcome that?
This led to two main therapeutic approaches to harness the incretin effect. One, developing metabolically stable analogs or derivatives of GLP-1 that resist enzymatic degradation or renal clearance. These are the GLP-1 receptor agonists. Two, developing inhibitors of DPP4 to prolong the action of endogenously released GLP-1 and GIP. These are the DPP4 inhibitors.
Let's explore the glucagon-like peptide 1, GLP-1 receptor agonist first. What are the available drugs in this class and what are their key features?
The available GLP-1 receptor agonists include dulaglutide, exenatide and its extended release form, liraglutide, lixisenatide, and semaglutide. Exenatide, a derivative from Gila monster venom, is designed to resist DPP4 degradation. It's injected subcutaneously before breakfast and dinner, peaking at about 2 hours with a duration of up to 10 hours. A once-weekly extended release formulation is also available, providing more convenience.
How effective is it?
When added to sulfonylurea therapy, the sulfonylurea dose may need to be decreased to prevent hypoglycemia. Exenatide typically lowers HbA1c by 1.2% and results in weight loss of 2-3 kilograms, which is a desirable side effect for many type 2 patients. It's not approved for use in patients with eGFR less than 30 LL-min 1.73 ml due to renal clearance. High-titer antibodies against exenatide can develop in some patients, about 6%, potentially attenuating the glycemic response. Liraglutide is a soluble fatty acid acylated GLP-1 analog. Its modifications allow for non-covalent binding to albumin, which both hinders DPP4 excess and contributes to a prolonged half-life, approximately 12 hours, enabling convenient once-daily dosing. It reduces HbA1c by 0.8 to 1.5% and leads to weight loss ranging from none to 3.2 kilograms. A higher dose, 3 milligrams daily, is also approved for weight loss in non-diabetic patients, highlighting its efficacy beyond just glucose control.
Liraglutide also had significant cardiovascular benefits, right? This is a major game changer for GLP-1 RAs.
Yes, this is a major game changer for GLP-1 RAs and a critical insight for an elite professional. The landmark LEADER study showed that in type 2 diabetes, patients with known cardiovascular disease, adding liraglutide was associated with a significantly lower risk of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. Hazard ratio 0.87, p equals 0.01. This wasn't just about glucose control, it was a direct benefit on major heart outcomes. Patients also experienced lower HbA1c, weight loss, lower systolic blood pressure, and fewer severe hypoglycemic episodes, showcasing a holistic benefit.
And what about the other GLP-1 RAs like dulaglutide and semaglutide, which offer less frequent dosing?
Dulaglutide consists of two GLP-1 analog molecules covalently linked to an Fc fragment of human IgG4, which resists DPP4 degradation. It has a long half-life of about 5 days, enabling convenient once-granted subcutaneous injection. Lixisenatide is a synthetic exendin-4 analog with a shorter half-life of 3 hours, injected once daily. It lowers HbA1c by 0.6% and causes weight loss of 1 to 3 kilograms. Antibodies to lixisenatide are frequent, occurring in 70% of patients with attenuated glycemic response in 2.4% of patients with the highest titers. Semaglutide is a synthetic GLP-1 analog with a long half-life of about 1 week due to DPP-4 resistance and albumin binding. It's administered once weekly subcutaneously and provides significant HbA1c lowering, 1.5 to 1.8%. Interestingly, an increase in diabetic retinopathy was observed in one clinical trial, possibly due to the rapid glucose lowering, which requires careful monitoring. What about oral semaglutide? It seems like a major advancement in terms of patient convenience. It is a significant breakthrough in convenience. Oral semaglutide, Rybelsus, is co-formulated with sodium N8-2-hydroxybenzoyl aminocaprylate, SNAC, which creates a complex that is lipophilic and resistant to proteolysis, allowing for oral absorption. However, its oral bioavailability is very low, only 0.4 to 1%, meaning it must be taken strictly fasting with a glass of water, and the patient must wait at least 30 minutes before eating, drinking, or taking other medicines to ensure maximal absorption.
What are the most frequent and serious adverse reactions for GLP-1 RAs? These are important for patient counseling.
The most frequent adverse reactions are gastrointestinal, nausea, 11 for 40%, vomiting for 13%, and diarrhea, 9 to 17%, which are generally dose-related and tend to improve over time. More seriously, all GLP-1 receptor agonists may increase the risk of pancreatitis, so patients must seek immediate medical care for unexplained persistent severe abdominal pain. Cases of renal impairment and acute renal injury have been reported with exenatide, potentially linked to volume depletion from severe GI side effects.
Any other major warnings?
Finally, both exenatide and liraglutide stimulated thyroidal C-cell tumors in rodents. While human thyroidal C-cells express few GLT-1 receptors, the relevance to humans is unclear, so these drugs are contraindicated in persons with a history of medullary thyroid cancer or multiple endocrine neoplasia, MNN syndrome type 2.
If one incretin is good or two better, let's discuss the very new dual GIP-GLP-1 receptor agonists like tirzepatide, which combines two gut hormone pathways.
This is a very exciting and potent development. Tirzepatide is an analog of the GIP hormone, but it uniquely binds to both GIP and GLP-1 receptors, hitting two incretin pathways simultaneously. Its acylation leads to albumin binding, allowing for convenient once-weekly dosing, much like some of the longer-acting GLP-1 RAs. It starts at 2.5 milligram weekly and can be titrated up to a maximum of 15 milligram weekly.
And what are its effects on glucose and weight? Is it more powerful than single agonist drugs?
What's fascinating here is its efficacy. Tirzepatide has resulted in impressive dose-dependent HbA1c reductions ranging from 1.9% to 2.6%, which is among the highest seen with non-insulin agents. It also leads to significant average weight loss from 6.2 to 12.9 kilograms, making it a very powerful tool for weight management in type 2 diabetes. Beneficial effects have also been observed on lipid profiles, blood pressure, and fatty liver.
And the safety?
Its safety profile is similar to GLP-1 RAs, with GI side effects, nausea, vomiting, diarrhea, occurring more frequently at higher doses, and a slightly higher rate of pancreatitis noted in trials.
Now let's look at the other side of the incretin coin, that peptidyl peptidase 4 DPP-4 inhibitors. How do these differ from the GLP-1 agonists, since they both affect incretins?
Instead of mimicking incretins by directly activating their receptors, DPP-4 inhibitors work by blocking the enzyme DPP-4, which rapidly degrades naturally produced GLP-1 and GIP. By inhibiting this enzyme, they raise the circulating levels of these endogenous incretins, thereby achieving similar effects, increasing glucose-mediated insulin release, lowering glucagon, slowing gastric emptying, and decreasing appetite.
Which ones are available?
The available drugs in the U.S. include alogliptin, linagliptin, and sitagliptin. Saxagliptin has been removed from the U.S. market.
Can you give us specifics on a couple of these, perhaps highlighting their differences in terms of elimination?
Sitagliptin is typically given orally as 100 milligrams once daily, with high bioavailability and a half-life of approximately 12 hours. It's primarily excreted in the urine, partly by active tubular secretion, so the dosage should be reduced in patients with impaired renal function. Therapy results in HbA1c reductions of 0.5, 1.0%. Linagliptin is given orally as 5 milligrams daily. A key feature of linagliptin is that it is primarily excreted via the bile, meaning no dosage adjustment is needed in renal failure, which is a significant advantage for patients with kidney disease who might have difficulty with renally cleared drugs. It lowers HbA1c by 0.4, 0.6%.
What are the common and serious adverse effects of DPP-4 inhibitors? Are there any that are particularly concerning?
The most frequent adverse effects appear to be nasopharyngitis and upper respiratory tract infections. However, more serious adverse effects include hypersensitivity reactions, such as anaphylaxis, angioedema, edema and Stevens-Johnson syndrome, which can be severe. The frequency of pancreatitis is unclear, but cases have been reported, so unexplained abdominal pain should be investigated. Cases of hepatic failure have been reported with alogliptin and vildagliptin, not in U.S., so liver function should be monitored for those specific agents.
Any heart failure or joint pain issues?
The FDA has issued a warning that saxagliptin and alogliptin have been associated with a slightly increased risk of heart failure in post-marketing studies. Additionally, the FDA has warned that DPP-4 inhibitors can occasionally cause joint pains that resolve upon stopping the drug.
Next, let's explore sodium glucose cotransporter 2, SGLT2 inhibitors. These are a relatively newer class that have made a significant impact. How do they work, and what's their unique mechanism of glucose lowering?
SGLT2 inhibitors represent a truly novel mechanism compared to other diabetes drugs. Glucose is freely filtered by the renal glomeruli, but about 90% of it is normally reabsorbed in the proximal tubules of the kidneys by the action of sodium glucose cotransporter 2, SGLT2. Inhibition of SGLT2 by these drugs causes glycosuria, meaning glucose is excreted in the urine, which directly lowers blood glucose levels in patients with type 2 diabetes.
So they essentially make you pee out excess sugar. What are the available drugs, and what kind of glucose lowering can be expected?
The approved SGLT2 inhibitors include canagliflozin, dapagliflozin, empagliflozin, and ertagliflozin. They reduce the threshold for glycosuria from a normal plasma glucose threshold of about 180 mg/dL down to approximately 40 mg/dL. They typically lower HbA1c by 0.51% when used alone or in combination, with greater efficacy at higher HbA1c levels because more glucose is available to be excreted. The loss of calories through glucose in the urine also results in a modest but beneficial weight loss of 2 to 5 kilograms.
This is where it gets really interesting and has been a major game changer. These drugs have demonstrated significant cardiovascular and renal benefits beyond just glucose lowering. This is a crucial insight for any elite professional.
Absolutely. The evidence for these benefits is compelling and has fundamentally shifted diabetes treatment paradigms. For example, in a large post-marketing study of type 2 patients with known cardiovascular disease, the addition of empagliflozin was associated with a significantly lower primary composite outcome of cardiovascular death, non-fatal myocardial infarction, or non-fatal stroke. The exact mechanisms are still being fully elucidated, but factors like weight loss, lower blood pressure, and diuresis likely contribute, as there were fewer deaths from heart failure, while MI rates were unaltered. This suggests a direct cardiac protective effect.
Were similar benefits seen with other SGLT2s?
A similar large multinational study with canagliflozin in type 2 patients with known or increased CV risk also showed a lower primary composite outcome of CV death, non-fatal MI, or non-fatal stroke. Hazard ratio 0.86, p-il 0.02. And dapagliflozin has shown remarkable benefits in heart failure. In a study of over 4,700 patients with heart failure with and without diabetes, dapagliflozin significantly reduced the cumulative incidence of worsening heart failure or cardiovascular death. What's fascinating is that this benefit was seen regardless of the patient's diabetes status, underscoring its broad heart protective effects beyond just glucose control.
And their renal protective effects. That sounds equally important for a common diabetes complication.
They're equally impressive. SGLT2 inhibitors have consistently shown benefit in reducing the progression of albuminuria, a key marker of kidney damage and progression of diabetic kidney disease. Canagliflozin, in a study of type 2 patients with chronic kidney disease, reduced the risk of end-stage renal disease, doubling of serum creatinine, and renal death. Similarly, a multinational study of over 4,300 patients with chronic kidney disease showed that dapagliflozin reduced the risk of end-stage renal disease or death from renal and cardiovascular causes. And remarkably, this benefit extended to a third of the patients in the study who did not have diabetes. These findings highlight their significant kidney protective role, even independent of glucose lowering, making them valuable in managing chronic kidney disease.
So given their kidney impact, what are the considerations for patients with existing renal impairment? Does their efficacy change with kidney disease?
The efficacy of SGLT2 inhibitors for glycemic control is reduced in chronic kidney disease, as there's less glucose filtered to be excreted. They can also transiently increase creatinine and decrease eGFR, especially in patients with existing kidney impairment. Their use for glycemic control is generally not recommended in patients with eGFR less than 45 ll-min 1.73 μ/2 and are contraindicated if eGFR is less than 30 ll-min 1.73 μ/2.
But the kidney benefits might still apply.
Yes. For their kidney protective benefits, the dapagliflozin study noted the drug was safe and beneficial in patients with eGFR as low as 25 mmHg 1.73 mL/2, demonstrating that the renal and cardiovascular benefits can extend to patients with more severe kidney disease even if the glucose-lowering effect is diminished.
Let's discuss their major adverse effects. These are important for anyone considering or prescribing these medications.
What's fascinating here is the distinct safety profile, which differs from other diabetes drugs. The most common adverse effects are an increased incidence of genital mycotic infections, for example, yeast infections, and urinary tract infections, affecting approximately 8–9% of patients. There have also been reports of more severe infections like pyelonephritis and septicemia requiring hospitalization. Additionally, rare but serious cases of necrotizing fasciitis of the perineum, Fournier gangrene, a very serious bacterial infection, have been reported.
Anything else? Volume issues?
Due to the glycosuria, they can also cause intravascular volume contraction and hypotension, especially in elderly patients or those also on diuretics.
Any other notable side effects, like on lipids or bones or even rare cancer concerns?
Canagliflozin and empagliflozin have caused a modest increase in LDL cholesterol levels, 4–8%. There have been some cancer concerns. Clinical trials with dapagliflozin had higher rates of breast cancer, 9 cases versus none in comparator arms, and bladder cancer, 9 cases versus 1 in placebo arm. These rates exceeded expected rates in an age-matched reference diabetes population, though causality is not definitively established. Regarding bone health, canagliflozin has been reported to cause a decrease in bone mineral density at the lumbar spine and hip. A pooled analysis showed about a 30% increase in fractures in patients on canagliflozin, and this is likely a class effect across SGLT2 inhibitors.
Yeah.
A modest increase in upper limb fractures was also observed, but it's unclear if this is due to bone strength or related to falls from hypotension.
And the amputation risk with canagliflozin?
One multinational study of canagliflozin showed an increase in risk of amputations, especially of the toes. However, this finding has not been observed in other studies using this drug or with other SGLT2 inhibitors, so the data there is a bit specific to that one trial.
And finally, a very serious adverse effect. Euglycemic diabetic ketoacidosis, DKA. This sounds particularly dangerous because it doesn't present with the usual high blood sugar.
This is a critical safety concern, especially for those who want to master this information. DKA typically occurs when there's an absolute lack of insulin, leading to very high blood sugar and ketone production. However, cases of euglycemic DKA have been reported with the off-label use of SGLT2 inhibitors in patients with type 1 diabetes and in type 2 patients who are very insulin deficient and prone to ketosis.
Why does it happen without high sugar?
The danger is that type 1 patients are taught to give less insulin if their glucose levels are not elevated. Because SGLT2 inhibitors can cause glucose excretion even at normal blood sugar levels, type 1 patients might see normal glucose readings, leading them to withhold or reduce their insulin doses to such a degree that they induce ketoacidosis without the typical warning sign of high blood sugar. Therefore, SGLT2 inhibitors are contraindicated in type 1 diabetes and in type 2 patients who are very insulin deficient and prone to ketosis.
Let's quickly review some of the other glucose-lowering drugs that fall into more niche therapeutic areas, starting with pramlintide, an islet amyloid polypeptide analog.
Pramlintide is an analog of islet amyloid polypeptide, IAPP, or amylin, a 37 amino acid peptide co-secreted with insulin. Physiologically, IAPP provides negative feedback on insulin secretion. At pharmacological doses, pramlintide specifically reduces glucagon secretion, slows gastric emptying through a vaguely mediated mechanism, and centrally decreases appetite. The proline substitutions in pramlintide make it soluble and non-aggregating for therapeutic use. It's approved for use in insulin-treated type 1 and type 2 patients.
How is it used, and what are its main side effects?
Pramlintide is rapidly absorbed after subcutaneous administration, peaking within 20 minutes, with a short duration of action of no more than 150 minutes. It's metabolized and excreted by the kidney, but there's no significant change in bioavailability at low creatinine clearance. It's injected immediately before eating. Doses range from 15 to 60 milligrams subcutaneously for type 1 patients and from 60 to 120 milligrams for type 2 patients. Therapy is initiated at the lowest dosage and titrated upward.
Any special precautions when starting it?
Crucially, due to the risk of hypoglycemia, concurrent rapid or short-acting mealtime insulin dosages should be decreased by 50% or more at initiation to avoid dangerous low blood sugar. It must also be injected using a separate syringe as it cannot be mixed with insulin. The major adverse effects are hypoglycemia and gastrointestinal symptoms, including nausea, vomiting, and anorexia. The slowed gastric emptying can make recovery from hypoglycemia problematic due to delayed absorption of fast-acting carbohydrates.
So where does it fit in overall?
While useful for selected type 1 patients with postprandial hyperglycemia, especially after high carbohydrate meals, it is generally less useful for type 2 patients who often benefit more from GLP-1 receptor agonists or SGLT2 inhibitors due to their broader benefits and easier administration.
Next, cholecyvalum hydrochloride, typically a bile acid sequestrant.
Cholecyvalum hydrochloride, primarily known as a cholesterol-lowering drug, is also approved as an antihyperglycemic agent for type 2 patients. Its mechanism of action for glucose lowering is largely unknown, but it's presumed to involve an interruption of the enterohepatic circulation and a decrease in farnesoid X receptor, FXR, activation. FXR is a nuclear receptor affecting cholesterol, glucose, and bile acid metabolism. It may also impair glucose absorption.
How well does it work?
In clinical trials, it lowered HbA1c by a modest 0.5%. Adverse effects include gastrointestinal complaints like constipation, indigestion, and flatulence. It can also exacerbate hypertriglyceridemia, which is common in type 2 patients. Overall, due to its modest efficacy and significant GI side effects, its use in diabetes is questionable and generally not a first-line option.
And finally, bromocriptine, a dopamine agonist.
Bromocriptine has shown very limited glucose-lowering effects in randomized placebo-controlled studies, lowering HbA1c by 0.2% compared with baseline and by 0.5% compared with placebo. The exact mechanism by which it lowers glucose levels is not definitively known, though it's thought to reset circadian rhythms involved in metabolism. Its main adverse effects are nausea, fatigue, dizziness, vomiting, and headache. Like cholecyvalum, its modest efficacy makes its widespread use in diabetes questionable in light of more powerful and better tolerated agents.
We've now covered the science and the drugs. But how does all this come together in the real world? Let's discuss the management of the patient with diabetes, the holistic picture that's essential for any elite professional. What's always the first line of defense, the fundamental element?
The foundation, always, is diet. A well-balanced, nutritious diet remains a fundamental element of therapy for diabetes. Macronutrient proportions, carbohydrate, protein, and fat, should be individualized based on the patient's eating patterns, preferences, and goals. Most patients typically consume about 45% of their calories as carbohydrates, 25-35% fats, and 10-35% proteins.
Are there any specific dietary recommendations or patterns that have shown significant benefits?
Limiting carbohydrate intake and substituting some of those calories with monounsaturated fats like olive oil, canola oil, or those found in nuts and avocados can effectively lower triglycerides and increase HDL cholesterol, both beneficial for cardiovascular health. A Mediterranean-style eating pattern, often supplemented with walnuts, almonds, hazelnuts, and olive oil, has also been shown to improve glycemic control and lower combined endpoints for cardiovascular events and stroke, making it a highly recommended approach.
What about weight loss?
For obese type 2 diabetes patients, caloric restriction and weight loss are incredibly important goals. Even a modest weight loss can significantly improve insulin sensitivity. Understanding the long-term consequences of poorly controlled diabetes can be a strong motivator for weight loss.
And are there medical or surgical options for weight loss in these patients when diet and exercise aren't enough?
Yes. For selected patients, medical or surgical options should be considered. Approved weight loss medications include orlistat, fentermine, naltrexone plus extended-release bupropion, high-dose liraglutide, and semaglutide, all used in combination with diet and exercise. Bariatric surgery, such as Roux-en-Y, gastric banding, or gastric sleeve, typically results in significant weight loss and can even lead to remission of diabetes, especially in the early stages.
What about non-obese type 2 patients?
For non-obese type 2 patients who frequently had increased visceral adiposity, sometimes called the metabolically obese normal weight patient, while less emphasis is on weight loss, exercise remains paramount for improving insulin sensitivity and overall health.
Beyond diet, education seems like a critical component that empowers the patient.
It absolutely is. Education of the patient and their family is a critical component of care, almost as important as the medications themselves. The patient should be fully informed about their specific type of diabetes and, crucially, the rationale for achieving target glucose levels. Glucose monitoring, whether through CGM or BGM, should be strongly emphasized, particularly if the patient is on insulin or oral secretagogues that can cause hypoglycemia, so they know how to identify and manage their sugar levels.
What should patients on insulin specifically understand to manage their doses effectively?
Patients on insulin therapy must understand the time-action profile of their insulins, how to determine if their basal insulin dose is correct, and how to adjust rapid-acting insulin doses for the carbohydrate content of meals, which is often done through carbohydrate counting. Insulin adjustments for exercise and infections are also vital topics for discussion, as these can drastically alter insulin needs. Furthermore, the patient and family members should be well informed about the signs and symptoms of hypoglycemia and how to respond quickly and safely.
When it comes to glycemic targets, is there a universal goal, or is it highly personalized for each patient?
The American Diabetes Association, ADA, provides general criteria for acceptable control: an HbA1c of less than 7%, 53 millimolar, pre-meal glucose levels of 130 milligdl, 57.2 millimol, and peak postprandial glucose of less than 180 milligdl, 10 millimol. However, these targets need to be highly individualized by a clinician.
How so? What factors lead to individualization?
For example, the HbA1c target may need to be modified for individuals on insulin or insulin secretagogues due to their increased risk of hypoglycemia. Less stringent glycemic control, for example, an HbA1c close to 8%, is often appropriate for children, patients with a history of severe hypoglycemia, significant microvascular and macrovascular disease, other comorbidities like coronary heart disease, and limited life expectancy. For elderly, frail patients, an HbA1c close to 8% may be entirely appropriate to avoid dangerous low blood sugar. Conversely, more stringent glycemic control is appropriate for newly diagnosed adults with limited comorbidities and a long life expectancy to maximize long-term benefits.
And CGM metrics are changing this too.
Yes. For patients using CGM, the time in range, TIR, and glucose management indicator, GMI, are increasingly used to tailor the diabetes management plan in addition to HbA1c.
So treatment strategies are always a stepwise and individualized approach. Let's look at type 1 diabetes first. How is insulin therapy designed to mimic natural physiology?
In type 1 diabetes, the primary goal is physiologic insulin replacement because the body produces little to no insulin. This is best achieved using a combination of rapid-acting insulin analogs for mealtime coverage and long-acting insulin analogs for basal support to mimic the body's natural insulin release patterns. A newly diagnosed patient may require minimal doses initially, as they might still have some residual endogenous insulin production, a phase sometimes called the honeymoon period.
How do basal needs change over time?
In patients with longer duration diabetes, the 24-hour basal insulin needs are usually based on age and body weight. An adolescent might need as much as 0.4 units a day, a young adult, less than 25 years, 0.35 units a day, and older adults, 0.25 units a day, highlighting the reduced need for insulin with age.
And how are mealtime doses calculated for these patients?
The meal bolus, rapid-acting insulin before meals, varies based on the time of day and the patient's age. Adolescents and young adults typically require 1 unit per 10 grams of carbohydrate, while older adults usually require about 1 unit for 15 grams of carbohydrate, reflecting differences in insulin sensitivity. The correction factor, how much insulin is needed to lower glucose levels by 50 milligdl, can be calculated from these insulin to carbohydrate ratios. For example, if 1 unit is required for 15 grams of carbohydrate, then 1 unit will lower glucose levels by 50 milligdl. If 1.5 units of insulin is required for 15 grams of carbohydrate, that is 1 unit for 10 grams of carbohydrate, then 1.5 units of insulin will lower glucose levels by 50 milligdl, meaning 1 unit will lower glucose level by 33 milligdl. These are approximate values and must always be individualized based on patient response. Table 41-8 provides concrete examples of intensive regimens using rapid-acting analogs and NPH or basal analogs like datamir, glargine, or degludec for a 70-kilogram person with type 1, illustrating various dosing schedules and considerations like carbohydrate intake and pre-meal glucose levels.
And for those on insulin pumps, how are the basal rates and bolus calculations handled?
For patients on an insulin pump, basal infusion rates are even more finely tuned. For example, a typical rate might be 0.6 units per hour throughout the 24 hours, with an increase to 0.7 units per hour from 4.0 a.m. to 8.0 a.m. to address the dawn phenomenon, a natural rise in morning glucose due to hormonal changes. Bolus ratios might be 1 unit for 12-gram carbohydrate plus 1 unit for every 50 milligdl of blood glucose above a target value of 120 milligdl.
And closed-loop systems are changing this.
The currently available closed-loop systems are a huge step forward, enabling patients to better achieve glycemic targets with reduced rates of hyperglycemia, and these systems should be offered to most type 1 patients due to their significant benefits in glycemic control and quality of life.
Now, let's turn to the pivotal evidence supporting this tight control. What are the benefits of tight glycemic control in diabetes? This is where the landmark studies truly cemented our understanding.
This is truly where the science speaks clearest and provides the foundational evidence for aggressive diabetes management. The Diabetes Control and Complications Trial, DCCT, a long-term randomized study involving 1441 type 1 patients across 29 medical centers, reported in 1993 that near normalization of blood glucose, mean HbA1c of 7.2% in the intensively treated group versus 8.9% in the conventionally treated group, resulted in a delay in onset and a major slowing of progression of microvascular and neuropathic complications of diabetes during follow-up periods of up to 10 years.
How big was the reduction in risk?
Over the study, there was approximately a 60% reduction in risk of diabetic retinopathy, eye disease, nephropathy, kidney disease, and neuropathy, nerve damage, in the tight control group compared to the standard control group.
And this glycemic memory concept, where earlier good control has lasting benefits, even if control fluctuates later. That sounds incredibly encouraging.
What's fascinating here is that the DCCT study indeed introduced the crucial concept of glycemic memory, sometimes called the legacy effect. During a 6-year follow-up period after the initial trial, even though both groups eventually had similar glycemic control levels, the intensively treated cohort still showed significantly less progression of carotid intimal thickness, a measure of atherosclerosis or hardening of the arteries. This demonstrates that periods of good control have profound long-term benefits on reducing complications, even if control cannot be maintained as perfectly later in life.
And the United Kingdom Prospective Diabetes Study, UKPDS, for type 2 diabetes, that was a massive study with profound implications for managing that condition.
The UKPDS was a very large randomized prospective study of 867 newly diagnosed type 2 patients over 10 years, many of whom were overweight and hypertensive. It showed that tight control of diabetes with a reduction of HbA1c from 9.1% down to 7% reduced the risk of microvascular complications overall compared with conventional therapy, which only reduced HbA1c to 7.9%. Critically, metformin treatment alone significantly reduced the risk of macrovascular disease, myocardial infarction, stroke in obese type 2 patients.
Can you quantify the risk reduction per HbA1c point?
Epidemiologic analysis of the study suggested that every 1% decrease in HbA1c achieved an estimated risk reduction of 37% for microvascular complications, 21% for any diabetes-related endpoint and death, and 14% for myocardial infarction.
They also looked at blood pressure control in the UKPDS, didn't they? And that had a surprisingly significant impact, too.
Yes, and that's another powerful insight from UKPDS. Tight control of hypertension in these patients had a surprisingly significant effect on microvascular disease, as well as conventional hypertension-related outcomes. Every 10 millimeter Hg decrease in systolic pressure achieved an estimated risk reduction of 13% for diabetic microvascular complications, 12% for any diabetes-related complication, 15% for death related to diabetes, and 11% for myocardial infarction.
Did the benefits last after the study ended?
Post-stutter monitoring 5 years after the UKPDS closure confirmed that the benefits of intensive management and metformin therapy were maintained, with the risk reduction for myocardial infarction becoming significant over the longer term.
So what does this all mean for the patient? The conclusion from both studies is clear.
These studies unequivocally show that tight glycemic control profoundly benefits both type 1 and type 2 diabetes patients, significantly reducing the risk and progression of both microvascular, eye, kidney, nerve, and macrovascular heart attack stroke complications over the long term. This is the bedrock of modern diabetes management.
Now let's apply all this knowledge to type 2 diabetes specifically, looking at the medical therapy algorithm in figure 41-6. How do clinicians approach treatment beyond initial lifestyle changes, given the complexity of the disease?
Normalization of glucose levels in obese type 2 patients can often occur with weight loss and improved insulin sensitivity. A combination of caloric restriction and increased exercise is necessary for successful weight reduction. For selected patients, medical or surgical weight loss options should be considered. For example, bariatric surgery typically results in significant weight loss and can lead to diabetes remission, especially in the early stages of the disease. For non-obese type 2 patients who frequently have increased visceral adiposity, sometimes called the metabolically obese normal weight patient, while less emphasis is on weight loss, exercise remains crucial for improving insulin sensitivity.
And the treatment algorithm itself. Where does medical therapy begin for type 2 and what are the steps?
Unless there's a contraindication, this is indeed a highly individualized decision for any elite professional considering multiple factors. Efficacy? DPP-4 inhibitors and SGLT2 inhibitors are of moderate efficacy, while sulfonylureas, insulin, pioglitazone, GLP-1RAs, and GIP-GLP-1RA are of high efficacy. Hypoglycemia risk, increase with sulfonylureas and insulins, effect on weight, weight gain with sulfonylureas, insulin, and pioglitazone, weight neutral with metformin and DPP-4 inhibitors, and weight loss with GLP-1 receptor agonists and SGLT2 inhibitors. Cardiovascular and renal benefits, a major differentiator in modern practice. GLP-1 receptor agonists like liraglutide, SGLT2 inhibitors like empagliflozin, canagliflozin, dapagliflozin, and pioglitazone have demonstrated cardiovascular benefits. SGLT2 inhibitors specifically delay the progression of diabetic nephropathy. Major side effects. Each class has specific risks: lactic acidosis with metformin, fracture risk, heart failure, and possible bladder cancer with pioglitazone. GI side effects and pancreatitis with GLP-1 receptor agonists, nasopharyngitis, joint pains, and allergic reactions with DPP-4 inhibitors. And genitourinary tract infections and ketoacidosis with SGLT2 inhibitors. Cost. Metformin and sulfonylureas are generally less expensive than newer agents, which is a significant factor for many patients.
So it's a very tailored approach to treatment selection. Can you give some examples of specific situational choices?
Absolutely. For patients with hyperglycemia, primarily after a carbohydrate-rich meal, a short-acting secretagogue like repaglinide before that meal may be a good targeted choice. Patients with severe insulin resistance may be strong candidates for pioglitazone. Those concerned about weight gain may benefit from a GLP-1 receptor agonist, or an SGLT2 inhibitor, which cause weight loss, or a DPP-4 inhibitor, which is weight neutral.
What about patients with existing heart or kidney issues?
The presence of cardiovascular disease, heart failure, or established diabetic kidney disease should strongly steer choices towards specific GLP-1 RAs like liraglutide and SGLT2 inhibitors like empagliflozin, canagliflozin, and dapagliflozin as a second or third choice due to their proven organ protection. If two agents are inadequate, a third agent is added, though data regarding the efficacy of such combined triple therapy can be limited.
When do non-insulin agents stop being enough and insulin therapy is instituted in type 2 diabetes?
When the combination of non-insulin agents, oral medications, and injectable GLP-1 or GIP-GLP-1 receptor agonists fails to adequately control glucose levels, insulin therapy becomes necessary. Various insulin regimens can be effective. Simply adding nighttime intermediate or long-acting insulin may improve fasting glucose levels and provide adequate daytime control. If daytime levels are problematic, pre-mixed insulins before breakfast and dinner may help. If such a regimen doesn't achieve adequate control or leads to unacceptable hypoglycemia, a more intensive basal bolus insulin regimen, long-acting basal insulin combined with rapid-acting analog before meals, can be instituted.
Should other drugs be stopped when insulin starts?
Importantly, metformin should generally be continued when insulin therapy is started due to its continued benefits. Other agents like pioglitazone, sulfonylureas, GLP-1 receptor agonists, DPP-4 inhibitors, and SGLT2 inhibitors can also be continued in selected patients, weighing cost, complexity, and adverse effects against the potential benefits of the combination.
Now let's discuss the immediate dangers, the acute complications of diabetes. The first and most common is hypoglycemia, or low blood sugar.
Hypoglycemic reactions are the most common complication of insulin therapy. They can also occur in any patient taking oral agents that stimulate insulin secretion, like sulfonylureas or meglitinides, especially in the elderly or those with renal or liver disease, due to impaired drug clearance. It's more frequent with long-acting sulfonylureas.
What are the symptoms and what's the dangerous phenomenon of hypoglycemic unawareness that professionals need to be acutely aware of?
Rapid development of hypoglycemia in persons with intact awareness causes signs of autonomic hyperactivity, both sympathetic, tachycardia, palpitations, sweating, tremulousness, and parasympathetic, nausea, hunger. If untreated, it can progress to convulsions and coma. However, here's where it gets really dangerous. In patients exposed to frequent hypoglycemic episodes during tight glycemic control, these autonomic warning signals can become less common or even absent. This acquired condition is termed hypoglycemic unawareness.
Why is that so dangerous?
When patients lack these early warning signs, they may not take corrective measures in time, leading to severe, untreated hypoglycemia with confusion, weakness, bizarre behavior, coma, or seizures, at which point they can't self-treat. The good news is that hypoglycemic awareness may be restored by preventing frequent hyperglycemic episodes for a period of time. Every diabetic person on hypoglycemic drug therapy should carry identification, bracelet, necklace, or card, and rapidly absorbed glucose.
And how do you treat hypoglycemia from mild to severe?
All manifestations of hyperglycemia are relieved by glucose administration. To expedite absorption, simple sugar or glucose should be given, preferably in liquid form. For mild hypoglycemia in a conscious patient who can swallow, dextrose tablets, glucose gel, or any sugar-containing beverage or food, like juice or regular soda, can be given. If more severe hypoglycemia has caused unconsciousness or stupor, the treatment of choice is 1 milligram of glucagon injected either subcutaneously or intramuscularly, or 3 milligrams of intranasal glucagon for adults. This may restore consciousness within 15 minutes, allowing oral sugar intake. In emergencies, medical services can administer 20-50 milligillers of 50% glucose solution by intravenous bolus over 2 through 3 minutes for rapid consciousness restoration.
The other major acute complication is diabetic coma. This sounds like a true medical emergency with different forms.
It is. The two main forms are diabetic ketoacidosis, DKA, and hyperosmolar hyperglycemic syndrome, HHS. Diabetic ketoacidosis, DKA, is a life-threatening medical emergency caused by inadequate or absent insulin replacement. It occurs primarily in type 1 diabetes, but infrequently in type 2 diabetes patients facing severe stress like sepsis or high-dose steroids. It's more frequent in patients on insulin pumps, often due to interrupted insulin delivery, and poor adherence is a common cause.
And the euglycemic DKA risk.
As we discussed, cases of euglycemic DKA have also been reported with off-label SGLT2 inhibitor use in type 1 patients and in type 2 patients who are likely quite insulin deficient, which is particularly insidious as it lacks the typical high blood sugar warning.
What are the telltale signs and symptoms of DKA, and how is it treated?
Signs and symptoms include nausea, vomiting, abdominal pain, deep, slow, small breathing, change in mental status, including coma, elevated blood and urinary ketones and glucose, and arterial blood pH lower than 7.3 and low bicarbonate. The fundamental treatment for DKA involves aggressive intravenous hydration and insulin therapy, along with careful maintenance of potassium and other electrolyte levels. Fluid and insulin therapy is highly individualized and requires frequent reevaluation based on laboratory results. Regular human insulin should be used for intravenous therapy, usually starting at about 0.1 OCO.
And hyperosmolar hyperglycemic syndrome, HHS, how does it differ from DKA, and who is most at risk?
HHS is diagnosed primarily in persons with type 2 diabetes and is characterized by profound hyperglycemia and severe dehydration. It's often associated with inadequate oral hydration, especially in elderly patients, other illnesses, or certain medications that elevate blood sugar or cause dehydration, such as phenytoin, steroids, diuretics, and calcium channel blockers, and conditions like peritoneal dialysis and hemodialysis.
What are the diagnostic signs?
The diagnostic hallmarks are a declining mental status, even seizures, a plasma glucose greater than 600 milligdl, and a calculated serum osmolality greater than 320 milligdl. Unlike DKA, persons with HHS are typically not acidotic unless DKA is also present. The treatment of HHS focuses on aggressive rehydration and restoration of glucose and electrolyte homeostasis. Low-dose insulin therapy may be required after initial rehydration.
Finally, what are the chronic complications of diabetes, the long-term impact on the body, if the condition isn't well controlled?
The late clinical manifestations of diabetes mellitus involve devastating pathologic changes that affect small blood vessels, microvascular disease, and large blood vessels, macrovascular disease, as well as cranial and peripheral nerves, the skin, and the eyes. These lesions ultimately lead to severe outcomes such as hypertension, end-stage chronic kidney disease, ESRD, blindness, autonomic and peripheral neuropathy, amputations of the lower extremities, myocardial infarction, MI, and cerebrovascular accidents, stroke.
And these serious complications correlate with how long someone has diabetes and how well it's controlled.
Exactly. The severity of these late manifestations correlates strongly with the duration of the diabetic state after the onset of puberty and, crucially, with the degree of glycemic control. There are also some differences between type 1 and type 2 patterns. In type 1 diabetes, end-stage chronic kidney disease develops in up to 40% of patients, and proliferative retinopathy, severe eye disease leading to vision loss, in about 25% after 15 years, with ESRD being a major cause of death. In contrast, patients with type 2 diabetes are more likely to have macrovascular diseases like MI and stroke as their main causes of death.
Any other major risk factors?
It's critical to note that tobacco use significantly adds to the risk of both microvascular and macrovascular complications in patients with diabetes, highlighting the importance of smoking cessation.
To bring all this together, let's revisit the case study of the 66-year-old obese Caucasian man with a 10-year history of diabetes from our source material. This patient was initially on metformin, then insulin, had an HbA1c of 8.1%, mild peripheral neuropathy, and significant proteinuria. What were his initial challenges that a professional would immediately identify?
This patient presented with classic challenges of long-standing, poorly controlled type 2 diabetes. He had significant insulin resistance evidenced by his high insulin dose, about 1 unit per kilogram per day, despite his ongoing hyperglycemia. A major gap was his lack of education about diabetes self-management, which is foundational. He also showed clear signs of microvascular complications with his peripheral neuropathy and substantial proteinuria, 3,007 milligram creatinine, along with uncontrolled hypertension and smoking, all compounding his risk for further complications.
So how was this complex case managed? What were the key interventions?
His management involved a multifaceted, holistic intervention, targeting his weight, glucose levels, and blood pressure, along with crucial lifestyle changes. 1. Smoking cessation. He was advised to stop smoking and provided counseling and cessation medications.
He attended structured diabetes classes and received individualized instruction from both a diabetes educator and a dietitian. This is crucial for equipping patients with the knowledge and skills for self-management. 3. Medication reassessment. Metformin therapy was reinitiated as its first line and beneficial, and importantly, his insulin doses were reduced. This is critical because simply increasing insulin in an insulin-resistant obese patient can exacerbate weight gain without effectively controlling glucose. 4. Adding a GLP-1 receptor agonist. He was then given exenatide, a GLP-1 receptor agonist, which contributes to glucose lowering and promotes weight loss, a key benefit for this patient.
And what were the outcomes of this comprehensive approach over time?
The outcomes were impressive. Over the next 3 years, the patient lost about 8 kilograms, and remarkably, he was able to stop his insulin altogether. He achieved excellent glycemic control with an HbA1c of 6.5% on a combination of metformin, exenatide, and glympyride, a sulfonylurea. This highlights the power of a comprehensive, tailored approach, reducing the burden of injections and improving control.
But his journey didn't end there, illustrating the chronic, evolving nature of type 2 diabetes.
No, it didn't, and this is a critical takeaway for professionals. He eventually regained some of the weight, and his HbA1c increased again. This required further adjustment. His glympyride dose was reduced, and an SGLT2 inhibitor was instituted. This was a tailored choice, specifically due to his persistent diabetic nephropathy, proteinuria, leveraging the SGLT2 inhibitor's proven renal benefits. His antihypertensive therapy was also optimized, leading to a significant decline in his urine albumin excretion, demonstrating the ongoing need for dynamic management.
So what does this all mean? What are the key learnings from this intricate case study for mastering diabetes management?
This case vividly illustrates several critical points for any professional in this field. The critical importance of weight loss in achieving target glucose levels in obese patients with type 2 diabetes. That simply increasing the insulin dose is not always effective or the best approach, especially in insulin-resistant patients. Sometimes, reducing insulin and adding other agents is key. The significant benefit of combining metformin with other oral agents and non-insulin injectables to achieve optimal control and address multiple aspects of the disease. And finally, the necessity of a tailored, adaptable, and multidisciplinary management approach where therapy is continuously adjusted based on the patient's evolving needs, challenges, and the emergence of specific complications like nephropathy. It's an ongoing, personalized journey that demands vigilance and expertise. #outro.
What an incredible deep dive we've had today. We've journeyed from the microscopic islets of Langerhans to the complex pharmacology of modern glucose-lowering drugs, explored the nuances of insulin and glucagon, unpacked the different types of diabetes, deciphered diagnostic tests, and examined cutting-edge therapies and delivery systems. We've gone deep into every concept in detail to help you truly master this complex field.
We've seen how critical a holistic approach is, encompassing diet, education, and carefully selected medications. The landmark studies, DCCT and UKPES, have underscored the profound, long-lasting benefits of tight glycemic control, and our case study brought that knowledge to life, demonstrating the power of tailored, evolving treatment plans.
So what does this all mean for you as someone now deeply informed? With the rapid advancements in continuous glucose monitoring and closed-loop systems, are we on the cusp of truly automating diabetes management, fundamentally transforming the daily lives of millions? Or will the human element of lifestyle and vigilance always remain paramount?
It's a compelling question. While technology aims to simplify and optimize, the patient's engagement, individual variability, and a skilled healthcare team's nuanced oversight will likely remain vital to navigate the complexities and continually adapt to individual needs and new scientific breakthroughs. The human touch and critical thinking will always be essential.
We hope this deep dive has not only equipped you with comprehensive knowledge, but also sparked new questions and a deeper appreciation for the science behind metabolic health. Keep exploring, keep questioning, and keep learning.